significant and what's not significant in terms of the manifestation. And so you kind of see here, we all agree these are really significant, right? If you have syncope due to interference, that's pretty significant. So you get the idea, these are the kind of the highest level things. But as you know, some of our degrees of interference are fairly trivial, and that's where we get into the next classes, like very transient, particularly if it just activates the sensor or things like that. That's not as important. And then some are really, minimal, like one beat inhibition. But what should we consider as the range of different kinds of things that can happen? And so we would consider inhibition as probably one of the biggest, failure to anti-bradycardia pace. And then on the tachy side, the flip side is we're going to inappropriate therapy, shock, et cetera. There is a potential that you can reset the device either to some kind of backup, typically parameters, or just other parameters. It can change the programming of the device. And then the most extreme is you can fry the device. You can basically damage the generator. You can even damage the leads. So those are some of the whole spectrum of what can happen. So let's consider some of those different elements. So one of the issues is really the filtering, frequency, et cetera. And you can see just in kind of nature, like a PVC, a T wave is different than the R wave in terms of frequency. So some of the ways we get around oversensing, for example, is just in terms of filtering. So that works well for some things, but obviously for others forms of signals, it doesn't work so well. So what are some of the key things environmentally we should think about? So if I were to ask you, what's the most common thing that you'll run into in the hospital? Which of the things do you think are the most common, probably? Anybody? Cautery, yeah, by far. I think that's, so that happens every day, right? We're using cautery in the OR and procedures, et cetera. So by far, I think that's the most common. But there are other sources. Lithotripsy, obviously we'll talk about MRI. Even ablation we don't see a lot of it. ECT, electric shock therapy, nerve stimulators, et cetera. So there's a whole range of different things, and we'll talk about defibrillation as well. So what are the to-dos regarding hospital environment EMI? So there are a few things you should be aware of, right? So you should know, what are the potential sources? Are there things that you can anticipate? Obviously, you want to have some idea how the patient's programmed, obviously whether the patient's dependent, et cetera. And then also the steps you need to do for reprogramming, so ICDs to monitor only. And then typically we want to recheck, particularly for the reprogramming concept, and then reactivate ICD therapy. So these are the basic to-dos that we would have in our hospital environment. Now, what are some of the things in the non-hospital environment that you would consider? So anybody throw out your kind of favorite source of EMI that's non-hospital? Anybody, in your practice have you come across? Sorry? Arc welding, yeah, very good. I don't know if you arc weld, but other people do. So, yeah. Other things that you kind of come up with? Security scanners, okay, great. I mean, you go into a lot of stores, they're going to have those scanners, right? Other sources that you can think of, like in the home or anything like that.
Someone mentioned something about pools. Certain pools have certain sorts of...
Excellent. Certain outdoor sources of water and electricity. So faucets outside, pools, like when you walk in and you have a rail that you touch, et cetera. So there are a lot of sources like that are also important to consider. We'll talk about those in just a moment. So intraoperatively, just back to that in the hospital, so we want to document, what we're starting with, the parameters, so you'll know if there's a change. So we should know what the parameters are to begin with. Then obviously our big category is the patient dependent or not. But the idea that if they're not dependent, the likelihood they'll have problems is much less. And so really that's the key issue. And if they're pacer dependent, then we really need to have asynchronous pacing. All right. So what about defibrillation cardioversion? I think you're all expert on this, but the key principle is you don't want to have it over your device, right? So the rule is roughly 6 inches, but that's pretty far. Sometimes it's hard to get that far away from your device because of just the proximity. But you don't want to have the paddles in that place. The adhesive paddles, obviously they're easier to make sure they don't move around too much. But if you ever use like the gel actually is conductive. So you don't want the gel to go over the device either because it'll short into the device. But I actually have seen somebody, either destroy the device or, certainly impair the device function requiring a revision. So you can actually damage the device. So that's the important thing. So typically you want to make sure there's a programmer available while you're doing the cardioversion. All right. So placement, this is the idea is to kind of show you want to go away from it, either from like a right anterior to posterior or far away at the apex, et cetera. So something of that nature to avoid the device where it is. All right. The next topic is something you're probably quite familiar with, and that's for MRI. So the history of MRI has been complex, you could say, and has evolved enormously, right? So there are a number of things listed here that are potential MR effects from obviously magnetic field, pacing, and then other things that in fact the field can modulate the parameters of the device, as well as it can affect the performance of the lead. And the most dangerous, or I should say the most dangerous, but the next thing to consider is actually lead damage, or heating of the leads. I'll show the absolute most dangerous thing here. And so these were actually, experimental studies where they basically put the experimental animal subject in the MRI scan with the device, and they were able to show extremely rapid pacing, hundreds of beats per minute. And you can see an example here, and then it would deteriorate into ventricular fibrillation. So that was where the field started, from this idea, both from experimental and clinical, that you could induce VF. And so with that context, obviously, for a long, long time, MRIs were considered, we can't do those. And really then, obviously, industry stepped up and basically created conditional MRI systems. In doing so, really was able to create a safety environment that we have today. And as I indicated in the bottom statement, most centers, I think most of your centers have some program where they take non-conditional patients and still do some form of imaging. That's variable as who is included in that, et cetera. Some centers, for example, do abandon leads, some don't do abandon leads, some do epicardial systems, some don't do epicardial systems. So there are a variety still in terms of that, but that's where we're moving, is there's more and more data that, if done cautiously, et cetera, that you can image many of these patients. So that's kind of the evolution of what's happening. So what should you do in terms of MRI? It's very similar to electrocardioversion, that you should know the parameters, be able to evaluate the patient ahead of time, either put them in the conditional mode and disable therapies, and then monitor them. So the monitoring obviously is a critical part. We're not exceptionally good at monitoring in the MRI environment, but that's really a key point. Maintaining voice-visual contact with the patient during the MR, and then telling them to alert you for any symptoms, et cetera. All right, great. These are just some of the tests that have been done, which have shown really minimal ability to change parameters, things like that. Very minimal effects, like brief inhibition, things like that. But there is a potential that you can, in fact, have even loss of function, et cetera. All right. So we talked about these. So phones really don't have much effect. We did this study years ago that I think I mentioned, that you theoretically can create EMI. So still the recommendations are to use the contralateral side for phone use, even though the incidence is probably quite low. We'll talk about theft equipment in a moment. Work environment are things like arc welding, big generators, et cetera. Welding, and then we talked about that, ungrounded faucets and pools. That's not an atypical situation. Someone reaches and then they get shocked. And there are so many miscellaneous causes. Many devices you'll see have been listed as documenting one beat inhibition, which is not very clinically significant. Some of our challenges are in the work environment because the patient says, gee, I want to work, but you're telling me I have to be cautious about this. So there needs to be some evaluation. I generally consult the manufacturers for their guidance in this area. Sometimes it's hard to get a sense of how strong their field is, but that's kind of what you're doing. And these are kind of the similar comments. We talked about this, about the cell phone, just using it on the contralateral side. Theft equipment. So this is a really interesting and kind of maybe bizarre thing. So theft equipment, because it uses this very high-powered magnetoacoustic system, it's extraordinarily powerful and is in just exact right range of pacemakers and ICDs. So you can, in other words, get a substantial amount of EMI. So people have been shown that it can activate the defibrillator, you can get inhibition, et cetera. So what are the recommendations? The recommendations are that people walk through and be able to walk relatively quickly through the theft detector. And in that, they'll just have potentially a brief detection or a brief inhibition. So you shouldn't go up to it and stand next to it. People have demonstrated that you can get shocked and you can't get inhibition. So those are the major requirements. Obviously, if you can't move very quickly, probably other arrangements should be made and you shouldn't be exposed to this kind of technology, this kind of EMI. So it is probably one of the more important clinically significant because of people, they're everywhere, that in terms of theft detection. All right. So the basic issue is education. We need to provide education to our patients. And then we've talked about kind of shielding. As people invent new devices, there's always a potential for some other interaction that you even see in the lay press, et cetera. So that's basically the overview. Any questions about EMI, any things like that? Anybody have any comments? So kind of straightforward, but obviously sometimes it's challenging because there's some new source that someone asks you about, and you don't really know a lot about it. So I usually consult the manufacturer, and they usually do have some guidance in terms of that. Any other thoughts or questions? Yeah, I mean. Great. So the new iPhones, in fact, have a magnetic source. And so they're actually pretty strong magnets. People have done kind of field measurements as to how far they are, but that's the major thing. I'm not aware of anything other than the magnetic signal force, et cetera. Great. Yeah. Yes.
Static magnetic field. Right? This is different from the RF signals that were studied years ago when we looked about interference. And the same kind of rules apply, right? You want to keep it about 6 inches away. But if you go on Amazon, there are all kinds of consumer gear you can buy. So the static magnetic field, the question is, what is the magnetic field that flips the Hall sensor in your pacemaker, right? And the international standard is 10 Gauss isn't supposed to flip the Hall sensor, and that's about 1 centimeter from an iPhone 12. But you can buy all these magnetic charms, I forget what they're called, on Amazon. I mean, if you go to Amazon, there's all kinds of things, and they tell you how strong, and you can get 1,000 Gauss magnets on Amazon, that you can wear around your neck. And you can just see, if somebody wants to wear a magnetic charm on it, all you got to do is look at the Amazon, posting, and imagine, it's sliding over your patient's device when they're sleeping to ward off evil spirits and stuff. So you just know that the key point is that the advent of these neodymium magnets, which are cheap, ubiquitous. Now, people are finding clever consumer reasons to use them, and you just don't know what they're going to be in. So I think that's not a trivial consideration.
Great. Thanks, Dr. Swerla. Great. All right, any other questions about EMI? Otherwise, we'll go to our next talk and ask Dr. Russo to join us. So this next talk is really designed to look at some of the ethical, particularly end-of-life issues that devices raise. And so it is we're actually showing you the new QR code. So if you could just take a moment, we will be asking you to, vote. So if you'll just take a moment to, take a picture of this, that would be great. We'll give you a moment to do that. Okay, everybody good? Okay, great.
Great. Thanks again for all joining us again this morning. And this is, I think, sometimes the harder discussion, right? Because we're so used to doing everything to save lives and put in devices to make people feel better. And so I think this is a good thing to bring up at this meeting because it's reality, right? So let's start with the first one. The whole objective is to describe the framework for decision-making regarding end-of-life issues in patients who have implanted devices and to be able to describe steps to optimize the communication with patients about these issues with devices and trying to figure out when to have that discussion. So the first of these are going to be little, cases, and so to hear your thoughts, and I suspect we'll have, different, we're going to have different thoughts about the topics here, but an 89-year-old with a dual chamber ICD had an acute MI and cardiogenic shock. He's responsive only to deep pain. An advance directive is in place. That was very nice. And the family agreed with plans for comfort measures and did not want to prolong his life. So is it acceptable to turn off the tachycardia therapies? So if you could vote on that, yes, no, or you need an ethics consult. So what do people think about that? Do you question that in your practice? There you go. So everyone was unanimous and felt that this is appropriate. The patient had an advance directive in place, which is nice. So the family knew what the patient would want and they agreed with that. Straightforward. They're not all as easy as this. Okay, next, thanks. And we're going to alternate here.
Actually.
Is there more? There might be some
more slides.
Yeah, there are a few more slides. Sorry. Yeah. So withdrawal of pacemaker ICD support. So you have to consider the ethical issues and the need for discussion with the patient and family. So you need, if they're able to make decisions. The patient is the decision maker, right? If they're competent. The family, if they're not or confused, is certainly, and you still want to involve the family even when the patient's awake because they need to be part of the discussion too. That the patient could have that discussion. They're the final decision maker, but we don't keep it secret, unless the patient asks to keep it secret. But most of the time, that's not an issue. Next. And so the legal right of autonomy, so what it is a patient with decision-making capacity has the legal right to refuse or request the withdrawal of any medical treatment or intervention, regardless of whether she or he is terminally ill and regardless of whether the treatment prolongs life and its withdrawal results in death. So, there's the legal right and then you have the ethical side of things, but this is the legal part. And there was a consensus statement. I think it's interesting, a lot of these statements are updated every now and then, but you can see this one's from 2010, and there's really not an update to this, at this point. And so, maybe these things don't change, or maybe they do. And there's also, differences by country, right? We're talking about the United States here. There are different, things that, come up from other countries, from Canada and other places.
Great. So I'll take this. 83-year-old woman with complete AV block, dual chamber pacemaker, presents with severe intracranial hemorrhage. She's unresponsive. An advance directive is in place. The family agrees with plans for comfort measures. It did not want to prolong her life. Is it acceptable to turn off bradytherapies? Yes, no, needs consult. So same questions, ask you to, so a little different because it's bradycardia therapy in a dependent patient. Yeah, so this is really, as we ask this every year, this is a difference, right? So the tachytherapies, we had pretty uniform agreement, yes, I would do this. And for bradycardia therapy in a dependent patient, where you think that, in fact, the impact of withdrawing the pacing could be fairly immediate, you have a different split, right? So that's exactly what we have to deal with. And so, okay. So the additional thing is, if I'm not comfortable, am I compelled to do that? So, this is presented, the decision is made to do this, and they go to you and say, well, it's your turn to do this. Are you compelled to do it? And so the answer is yes, exactly right. You're not compelled. So, and so it says basically, if it violates the clinician conscience, the clinician should transfer care. So that is important. That is spelled out in the guidelines. That is your responsibility to at least attempt to find someone else to take over this care. So that's at least the thought. And so the related to what Andrew has mentioned, the concern is for this patient, is that the same as assisted suicide or euthanasia? And at least the guidelines say this: in withdrawing an unwanted therapy, the clinician's intent is not to hasten the patient's death, but rather to remove a treatment that is perceived by the patient as a burden. So the distinction is subtle, as you all appreciate, but these are the guidelines that we have currently. And so how is assisted suicide or euthanasia different than this? So in contrast, in assisted suicide, the patient intentionally terminates his or her own life using a lethal method provided or prescribed by a clinician, intentionally terminates. And second, in assisted suicide, the cause of death is intervention provided, prescribed, and administered. So the distinction is subtle, right? One is an intervention it's doing, and one is the withdrawal of therapy. That's the distinction being made. So, as you saw, you may or may not agree with that, but those are indeed the guidelines.
Yeah, and that is a hard thing when you get into Brady pacing, because you're there physically, and things could be relatively quick if they're dependent. But so, 83-year-old woman with complete AV block and a dual chamber pacemaker presents with severe intracranial hemorrhage. She's unresponsive. There is no advance directive in place. Who makes the decision? Do you need a court-appointed decision maker? Do you call the ethics committee? And this patient has no hope of meaningful recovery, or a patient's legal surrogate. So what is the U.S. Process here?
So there may be differences, either institutionally, right? So if it happens that presumably in an institution, there may be institutional guidelines and policies that may require one of these specific things, or state law, et cetera. So there is going to be a variability. So, we just ask that you consult these different groups.
Yeah, and so, so that's the answer. In the United States, the legal surrogate is the appropriate one, but I see there was maybe one person who said ethics committee, and at our hospital, reality is we would consult the ethics committee in that one. I think part of it depends on what the current feeling is of the clinicians that are working there. If people feel comfortable with that process, maybe there may be many who don't, and you kind of want some other involvement in some better, and also in this topic, I think the understanding of what's legal and what's needed is not something we really talk about, right? We don't talk about so much in EP fellowship training. We talk about it here, but it's not one of our core lectures. It's not on the boards. It's not one of those things that we really review frequently. So in the United States, most states specify a law of hierarchy of surrogate decision makers, and there's a spouse obviously is the first one. It would be in line for that. Clinicians should be aware of the definition of a legal surrogate in their states.
Great. Okay, this is mine, I guess. 83-year-old woman with complete AV block, dual chamber pacemaker, presents with end-stage metastatic cancer. She remains lucid. The patient declines further treatment. Is it acceptable to turn off bradycardia therapies? Let's go ahead and vote. So, more complex. Yeah. Yeah, you can see, right? This is very, very complicated. You'll have a lot of discussion. I think, I think it's quite appropriate. So you can see how that's shifted, right? We've gone from the very beginning where people were pretty comfortable with tachytherapy, withdrawal, bradycardia, and then now you have a very definitely lucid patient. So we have a lot of different issues here. All right, so we'll go back. So, according to the guidelines, this is actually true. It says clinicians should consider options about how to make the patient comfortable prior to distinguishing bradycardia therapy in the lucid patient as pacemaker dependent. So I would add that. If you are ever asked to do this, do not do it while the patient is lucid. And so that's an important thing to consider.
And I think also sometimes, if you just told them and then they're like, it takes a little while to, maybe a week from now, they feel a little different. But at that moment of just getting the diagnosis is probably not the right time to do something, is to, let the patient, think about it a little bit and before in a pacer-dependent patient, give them some time, right? A 73-year-old man with coronary disease, severe ischemic cardiomyopathy, and ICD was implanted. How does the patient voice his or her wishes about end-of-life care? And so, the whole concept of this whole advanced care planning is something we probably don't do enough. When should we do this? And it's a process that promotes the patient autonomy, which identifies his or her values and preferences and goals regarding future care, and a surrogate decision maker in the event that the patient loses decision-making capacity. So, bringing it up, and should we be bringing it before the device is implanted, shortly thereafter, before they have that terminal illness? Yeah, probably. And then also, I think someone brought up yesterday a case where a patient thought, well, if I don't want a device because I want to, I'd rather die suddenly, in a situation if I have a terminal illness. So to bring up that this device can be turned off, it might be a reassuring thing for the patient. And so, the patient should have decision-making capacity. Attempts to reverse illnesses that impair the patient's capacity, should be made, and determine, if there is an advance directive, and if it's not appropriate, then get a surrogate decision maker involved. I mean, they may be on, getting medications that decrease their capability of making the decision. And the patient, would be fully informed about the illness when the patient, isn't able to kind of make the decision at that point. The patient's request should be consistent with previous requests. And before withdrawing life-sustaining treatment, the care team should arrange for palliative care. If the clinician objects, again, another clinician could be involved so you don't have to do something you don't feel comfortable with, whether it's ethical or religious or other reasons. And then if it's ambiguous, consult the ethics, service. They can help you, can help the family, can help the whole team be able to understand this process better. The order to deactivate the device, though, should be written by the attending. You can't just ask the rep to go over and turn off the device. That's just not appropriate.
Great. Any questions? So in your practice, in your training, who's been asked to inactivate tachytherapies at end of life? So a lot of people have. Have you in your work ever been asked to inactivate bradytherapies in a dependent patient? Oh, yeah, so a few. Oh, okay, yeah. So you know what that's like, yeah. So, yeah, very good.
Okay.
Good, any other thoughts about these kind of issues? Yeah, thanks. Oh, that's a good one.
Different scenario.
Yeah.
You're not actively turning it off.
Yes. Yeah, so I'm going to repeat that so everybody hears. So what about the dependent patient that comes up for generator replacement? What's that discussion like in terms of, I want to have it changed or I don't want to have it changed, et cetera, right? So yeah, quite complex, right? And family dynamics, the family says, oh no, you got to get it changed. Oh no, I don't want it changed. So, that kind of thing.
Mm-hmm. Yep.
And other thoughts? Yeah, thank you.
Pacemaker independent patients that are not dependent.
Yeah.
That have like sinus bradycardia that don't want therapies. How does programming go about just turning everything off, bradytherapies and stuff?
Yeah. So let me just repeat that to make sure I get. So a non-dependent patient, but has a pacemaker, and they're end of life. right? What would be appropriate or not? So yeah, this happens a lot. And so many people will say exactly that. I want you to turn it off. I think the thing that you probably maybe been exposed to is the patient or the family do not have an understanding that probably has no impact on their outcome, right? They think, oh, well, you turned it off, they're gonna die. And when they sit around waiting and they don't die. And so, no, their illness is much more complicated. It's probably not gonna make the difference, something like that. Is that kind of where you're going with that? Yeah. Yeah, I think that's right. That happens a lot, right? People think that that's gonna happen right away, and generally not. I mean, even if they're a little bradycardic and, so, okay, you turn off the brady pacing, but their rates are still 45, 50. They're not going to die of that, right? So,
Right.
Good. Thank you.
So kind of what I've found is normally as a consultant, we try to back away from all these situations and let primary team take care of it, and answer, oh, when are you going to get out of here? Talk to primary team, But a lot of times they're not equipped to handle this, right? They don't understand that, escape rhythms and stuff. So I went through years without anything, and then this just came up recently. And we needed to be more involved because the primary team didn't understand, and they weren't able to have a good conversation with the patient's family. And that's tough coming in as a consultant and then driving that ship is weird.
I think that's actually a really great point. And then plus, if you're the one who's going to be turning off the therapies, I would feel uncomfortable doing that without having a discussion, myself. And so I think that also brings up, when do you talk about this? So as, the person, before or during or early on, before they're really sick and end stage, to bring up that topic so the patients are not completely surprised. So that's a hard thing to do in a busy practice, and it's hard to bring it up before the patient gets the device too. So, but I think that's a great point, is the team doesn't understand.
So I had to do it recently on a patient that was dependent, had a defibrillator that wanted it off. He was 100 years old, a former professor, and we had talked about it in clinic. I just wanted to share the mechanics of actually doing it. And so there's a little bit of coordination needed because he was in hospice, and the Medtronic person didn't feel comfortable going and turning it off. So I had to go and drive to the hospice location, meet the Medtronic person there. The second piece of this, sort of the documentation. So I documented this both in the clinic note and then in the hospice notes to make sure that everything was discussed with the family and said who was present in the room and all that sort of stuff, just kind of good documentation. And then the actual turning off of the device isn't sort of like, oh, turn it off. What I did was I turned off tachytherapy, and then I walked the device down in terms of rate. And actually he had an escape, which was kind of good. Made me feel a little bit better, and then turned it to storage mode, essentially, and then talked to them a little bit, left the room. He died about 8 hours or so later, and the family was very appreciative. They sent me a thank you card. I mean, it was ended up being the right thing to do, and I felt good about it in the end. But sort of the mechanics of doing it, there's a little bit of logistics and a lot of documentation, and then when you do it, you just walk it down and talk to the family about what to expect when you do it.
Yeah, that's great points, great advice.
Comments? I did want to mention something what Dr. Russo mentioned about how you talk to patients and when. So how many of you? So all of you consent people for device implant, right? I mean, everybody, right? So how many of you have seen either yourself or another provider use some kind of thing we call a shared decision-making tool? Anybody? For ICDs, sorry, yeah, for ICDs. So some people, right, many. Yeah, so that is an opportunity. Some of the, tools have that incorporated into it. What tools do most people use? Do you just yell out? Any particular tool that your own institution and other institutions, anybody?
Oh, the Colorado.
Colorado. Any other than Colorado? Anybody else use another one? your own institutions or anything? Yeah, so I use Colorado too. And there is a little section that says, well, why would you want to turn off the defibrillator? Well, if I develop an illness, typically, either it's cardiovascular or otherwise, I might want to turn it off, and that's okay. So there is an opportunity to not make it so extreme, but just within the conversation, well, it's going to have these complications, but this also is true that you might want at some point turn it off, et cetera. Yeah, so that's another opportunity, I think. Mm-hmm. Good. Anything else on this topic that people are interested or, kind of dying to talk about, so to speak?
I think this was brought up yesterday, but a lucid patient that has a primary prevention ICD that wants it out. Has never had therapies before, but for some reason they just want it out.
Yes.
How do you approach that patient?
Yeah, good.
Yeah, who's not at end of life, you mean, who there's just like, I had one of those not too long ago, actually.
Yeah.
That's a hard discussion, because now it's a procedure you're doing to the patient that has some risk. I mean, it's a relatively low risk. If you leave the lead in, I guess it's a lower risk. They do have the right. I think that they have a right to get the device taken out, but I usually, when I had this particular patient, I had the discussion, asked them if they want to, talk. I wouldn't recommend that. They had the device in, their EF is still 20%. You've gone through, the risks of implant and there's a risk of explant. I did actually, suggest, and I think I would recommend not doing it. Why don't you get another opinion? And I always think it's good, and if people are hesitant for anything, not just end-of-life decisions, but anything, for implanting a device and doing a procedure, encouraging them to talk to other people and other providers. And sometimes they change their mind and sometimes they don't. This one, it didn't change his mind, but, needed an extraction too. He wanted everything out. So, and that was done.
Yeah. So there are many ways to handle it. Obviously, I think, at least I personally would counsel the patient, well, why don't you start by inactivating the device, right? We'll just turn it off. Then, okay, no, I want it out. Well, why don't we just leave the lead in and we'll cap it and we'll take the device out? No, I want the entire device out. So I don't know. Honestly, if it were a high-risk situation, I might refer them just to somebody else and say, I'm not comfortable with that. That doesn't make a lot of sense to me. You're going to take some risk, and, but you probably clearly have the right to do that. But I'm not sure I would advocate that. So, yeah. Good. Other questions?
I have a question that's totally different scenario than all of these, and it may not have an answer. As much as I've run into a few times where patients refuse to get an ICD because they're commercial drivers. And ironically, at least my local laws, you can drive a truck with an EF of 15, but once you get an ICD, they will not renew your license.
Yeah.
Have you run into these scenarios? Do you have advice if these are scenarios of which you encounter?
Yeah.
The episode, so by state, and there's even different regulations in terms of loss of consciousness. So, if they've had, and seizures are included, like there's a seizure, I think it was originally made, for seizure disorders, at least like one state, is 6 months, and then the one right next door is 1 year from the last episode of loss of consciousness. So, for regular driving, this is not the commercial license. The commercial licenses are much more stringent, bus drivers, things like that. But you're right. Because if you get therapy for your arrhythmia, so logically speaking, but it's not based on the science, you're safer if you have an ICD, theoretically, right? Then because you'll get therapy. Could you lose control of the vehicle when you get shocked? I guess that's a possibility, but we do everything we can to minimize shocks, right, with all the things we have. So we've had that situation, and then usually I kind of wind up as they'll find something else at their job, or they'll go on disability if they can't get another job, and that's not what we want. We don't want for them, but most of the time they could find something else to do that's in their workplace.
Yeah, great question. Other thoughts? Any questions from the remote audience? Rich?
Yeah, I don't know if this has been answered, but an ICD implant, a DNR patient, is a responsible implant or just program ATP? You basically said.
Yeah, the question is, can you briefly talk about ICD implantation in a DNR patient? Is it reasonable to implant and just program ATP?
So, one of the things in our guidelines for implanting a device for, primary prevention is about 80% of the devices or so that are implanted, but is that they have to have, a chance of living, a good chance of living a year. So, and in someone who's a DNR, it's kind of like the opposite of what you would think that patient would want if they're a DNR. The other thing is ATP could certainly accelerate things, and you can induce VF and can kind of be a negative thing. So we don't have, I don't think that's a good idea for sure. But if they're a DNR patient, I'm not sure why they would want a device, Yeah, but that's a good question.
I would think so. I mean, first I was thinking, well, is it a quality of life issue? But then they're DNR, you think, well, gee, that would be kind of what you might want to do, right?
So maybe that's it. Maybe it's like a CRT device for quality of life and shortness of breath. That might be, so a pacemaker, and they're bad heart failure and they want to try something. I mean, I don't think that's completely out of the question. But then we have a policy. You have to revoke that DNR, within a short period of time after implant, just in case you have a complication or you need to deal with something. Again, not likely with a device implant, but at least allow us to treat you. Fusion or perforation, something like that for 48 hours or so after the procedure. But yeah, for quality, you could argue. That depending on what the state of the patient is.
Great. All right. I think we'll go to the next session. We'll ask our other faculty members. You want to come on up?
Please.
You can come on up. And if you could put up the next slide deck real quick.
So these are just some cases. I'll start with a couple. I don't know how much time. These are a little different. Is indications. We'll start with the first two cases are indications for device, Brady or TACI device therapy. So
so we're good on time. We're a little ahead. It's 8:20, so we've got a few minutes. So just give us some warning.
Should I grab that or your?
Go ahead.
Great. Okay, thanks. So the first case is a 56-year-old male with coronary disease, with anterior wall infarct 3 years ago, had a PCI to the LAD at that time, ischemic cardiomyopathy that's been, EF 35 to 40%, has class 2 heart failure, comes in the ER now with chest discomfort, is on, some heart failure medications, and this is the EKG. So if people want to just take a peek at that, you could see you're in sinus rhythm, and you could see the anterior infarct and, pretty extensive Q waves across the precordium. We have a narrow, QRS complex here. Troponins are normal. ECG reveals mild MR, severe anterolateral hypokinesis to akinesis, and apex is a little dyskinetic. Otherwise, mild global hypokinesis. EF's about 20% now. Cath on the current admission reveals 3-vessel coronary disease, and bypass surgery is recommended. And the patient has bypass surgery, is revascularized as much as they can, but post-operatively develops, and this is real life, right? Atrial fibrillation, rapid ventricular rates, post-conversion pauses up to 6 seconds, and they were not on any, beta blockers or anything at this point in time. And still they're having this, Brady TACI kind of thing going on for, 2 to 3 days after surgery with intermittent, they still have their epicardial wires in place and have intermittent pacing through the epicardial wires. So what would you recommend? A dual chamber pacemaker, a CRT pacemaker, dual chamber ICD, or a CRT ICD? Now, are they able to vote on this, or is that app valid for this also, or is that?
Right, we can vote on this, right?
There you go. Okay, great.
Yes, absolutely. Yeah.
All right. Well, that was quick voting. All right, let's see. Can we go back and, okay, so we have, very interesting, and that is what I would sort of expect, is some people said a dual chamber ICD, and others said a dual chamber pacer. And I'm going to ask the panel if I can not step in front of you so you can actually be seen.
Go ahead.
Well, it's the challenge of EP, right? We're asked to be fortune tellers in terms of what's going to happen with the patient moving forward. So my approach to these patients to try to figure out, am I going to want to upgrade them in a few months if I do intervention A? In which case, let's just do intervention B. So I'd probably be the same and favor dual chamber ICD to avoid a reoperation in a couple of months if I'm wrong.
The patient needs a pacemaker.
Yeah, I mean, I agree. The EKG, you suggested a pretty extensive MI, you had akinesis. It's certainly within reason that the EF is not going to improve dramatically. And so hedging your bets, I think one procedure, dual chamber ICD in this patient, I think is the right answer.
What would have made you decide, so let's say you decide dual chamber ICD, are there any patients that you would go ahead and say, well, I'll do a CRTD instead? Well, what would have to be present for you to
I guess I didn't look as carefully at the EKG, but one of the issues was that they were having some need for pacing, and I don't know whether, I can't remember if you said it was sinus node or if it was a narrow QRS, then I would say if it's sinus node, then probably dual. If you expect that they'll V-pace a fair amount, then you can consider CRT, but I think in somebody like this, the expectation is they've got good AV conduction, probably a dual.
Mm-hmm. So, the thought also of not having to go back, so, 3 months later. And so one of the things is, what's in the guidelines is based on the evidence and based on the literature and studies, and what is part of, that's a little more complicated than that. What are the reimbursement systems, like in the United States? And again, this is more of a country-related thing, and how do you do what you think is best for that particular patient? So I would go with the dual chamber ICD in this case, thinking, oh my goodness, I'm going to have to, 3 months if that EF doesn't get better. He's had an old infarct for many years. His EF was kind of pretty low to begin with, a long time ago, and wasn't referred. Maybe it was borderline 35-40, but I would also go with the dual chamber ICD. So what do our guidelines say based on the evidence, and based on the enrollment, and the evidence is based on the enrollment criteria in different clinical trials. So if they were excluded, that wasn't part of the guideline recommendation. So a class 1 recommendation, high level of evidence, multiple randomized trials in patients who have an EF of 35% or less, that's due to ischemic heart disease, at least 40 days post-MI. So he meets that, right? He didn't have a recent infarct. That was an old infarct. Troponins were normal. At least 90 days post-revascularization. Okay, that's not this case, right? Because he just had surgery, bypass surgery. New York Heart Association class 2 or 3 heart failure, an ICD is recommended if you have a meaningful survival of greater than 1 year. So what if, the EF doesn't improve in 90 days? We talked about, does the pre-existing cardiomyopathy play a role? And I think I'm hearing, it's not likely to improve, over time. He's got a big scar. And do the rules for reimbursement, are they consistent, or are there, is there a discordance between our reimbursement system in the United States? There's, lots of discordance with that, I think, but, in this particular topic, and does that need to play a role? And how do you deal with that in terms of your documentation, and does your hospital have any specific, policies? Now, I unfortunately had the experiences when I first moved from Penn to my current center is the Department of Justice was looking around. There was this, CMS, the NCD, the National Coverage Determination for ICDs, has this in it. It actually has exactly that you need to be 90 days from your revascularization, whether it be a PCI or a CABG. And so these lawyers came out and they looked at all the charts, and we had lots of them and a lot fell in this category as a matter, or not necessarily the pacemaker, but pre-existing cardiomyopathy, and they're just getting their medical care with you, and they may even have like valve surgery, one incidental bypass, and so that counts. So what they did is look at billing codes, and they pulled names and charts. Some of them were even, secondary prevention, because you can't tell that on the billing code, side of things. So a lot of them were, we said, they were very appropriate. It just, you couldn't tell it from the billing codes. But this is a tough one, in terms of the billing code in CMS. So if they're Medicare patients, 65 or older is what we're talking about on that national coverage determination, is we want to do the right thing as the physician caring for that patient. We want to do the right thing for that patient, and the right thing is to put that ICD up front, I think, because we don't want to bring them back in 90 days. Their EF is still in the 20s. boy, that's awful, right? They have to have their revision. They have to have that device. It's expensive too, but they have to have that device taken out. There's risk of a reoperation, risk of infection, and we know that that's not benign, to have another procedure. So one of the things, in the appropriate use document, and we're in the process of updating this now. It should be done in 2023. But it is one of the things, if you look at patients with coronary disease, this one is from 2013, prior MI, I don't think this is going to change, over 40 days with an ischemic cardiomyopathy. You can see here with that, you go down that, now they're within 3 months of bypass surgery, but this exact scenario, EF is low, is low at 35% or less, and they need a pacemaker. This patient needs a pacemaker, and it comes out as appropriate. So appropriate use is appropriate, right? So what I would do, and what we have to do is very specific because, especially at our hospital, because the Department of Justice had been there years ago, is, you got your warning, right? So now you have to, so we document in the medical record, obviously, this is appropriate, this is why you're doing it. We will mention the appropriate use, document that is consistent with that. And our hospital actually reviews every single ICD implant, and we'll look at the documentation. But still, the CMS coverage determination hasn't been changed. And if they are actually a Medicare patient, my understanding is they're still not billing for that device. They'd rather not bill than to, deal with damages. But it's kind of ridiculous in a way because this is really the right thing to do for the patient. So I don't know if other people have comments or questions. Yes.
You're saying that they don't bill for it, so the hospital just eats the cost of the ICD. Is that what happens?
Well, that's what they were doing as of about within a year ago, and because I think what they are, because if you have to pay damages, if you violate, will they come back again? No, and this is this isn't like happening every day, and it's not in Medicare patients necessarily every day. So that's one option and that's just what someone may decide, or the documentation may be enough. Just the documentation of all that thing. Some hospitals may say that that's fine, and we have good lawyers, and we're gonna deal with it if they come back, and they probably won't, but who knows?
Would you consider a micro investigation?
Oh, that's an interesting question. So actually, that's not a bad thought. And so you're putting in, so it's 6 sinus, so you don't have atrial pacing, but if you only have occasional pauses and it's not that they're chronotropically incompetent, you could put in a micro as a backup. And then in 3 months, if they need an ICD, I guess there's one of two options. You could, I don't know if you want to take that out, it probably wouldn't be socked in. You're still doing another procedure. You could leave it in, think of a subcutaneous or non-vascular device. You could do that. That's a good thought. I hadn't actually thought of that, but I guess you could consider that if you consider that, less invasive in some ways, but still invasive. Yeah, interesting. Other people think of that.
It's tricky though, right? Like if sinus node dysfunction is its primary issue, it's certainly nice to have an atrial lead in there to treat the problem. And then if you're going to put the atrial lead in and the EF is 20 and pretty sure it's not going to improve, it's nice to have a document that supports doing the right procedure first.
I agree.
Yeah, I think, again, writing and documentation is key. Documentation here is key.
I think we underestimate how important our notes are, like on all fronts, in terms of communication to other providers. Patients read their notes. Lawyers have to read the notes later on. So it is really important to be clear, and I don't think we pay enough attention to the quality of our notes a lot of the time.
Right. And they even have, and we don't use this, but they have this form that you could fill out, like that the patient agrees as if it's not covered, that the patient pays. To me, it sounds like, how do you have a patient pay for something like this, But, we don't fill it out, but that is another potential option. Yes.
Back to that case, just the micro question was interesting. And what you guys do this is my absolute least favorite scenario when there's a post-op AFib. And talk about an atrial lead and monitoring post-op AFib. Presumably that's new. That gives us more information to treat that aspect of it. It seemed like it was a post-conversion pause. And so I think we'd want an atrial lead for lots of reasons. Not to mention just the AFib too, to help decide treatment there. I don't know that.
Yeah. No, I do. I think that it's actually an interesting concept. That I hadn't thought of, but I agree. I would rather have an atrial lead because you're probably going to want to put them on something to maintain sinus rhythm. You're going to get maybe more bradycardic. Maybe that wasn't a problem pre-op, or maybe it was a problem and you just didn't really recognize it. You might want to give them beta blockers at least. You don't want his EF to get worse from rapid rates in AFib. So I think there's good reason to put an A lead. I think the clinically best thing to do for the patient is to do what was discussed. Yeah, great points. So some of these things, the thing that, in the appropriate use, scenarios is, you think, oh, that's pretty straightforward, but they're not straightforward. There's so many different scenarios, and there are over, 300 that are in that document. But, if you think about it, what we do every day, we think is simple, but it's not. It's a complex decision-making process, and it takes a lot of thought. A 72-year-old female with a non-ischemic cardiomyopathy, EF is 40%, has chronic heart failure, reduced ejection fraction, Class 2 heart failure, presents with dizziness. Had a cath 6 months ago, normal coronaries, is on a bunch of heart failure medicines and stuff. A repeat echo 2 months ago showed the EF was 45% with global left ventricular hypokinesis. And so this is the EKG in the emergency room with dizziness. Anyone want? I don't know if you could see it well enough to read it. Anyone want to give a stab or?
It's like complete heart block.
Yeah, got some P waves that don't go anywhere, and you have this, escape rhythm that's pretty slow. So she certainly has good reason to feel dizzy. So what would you recommend for her? Would you go with a dual chamber pacemaker? Would you do a dual chamber ICD? Would you do a CRT pacemaker or CRT ICD? So it's kind of the same choices. Maybe I have them in a different order. Yeah.
We don't have them.
Oh, you don't have that one?
We don't
Okay.
have.
Okay, so the majority said CRT pacemaker, some said dual chamber, and some said CRT ICD. And what does the panel think?
This scenario happens a lot, unfortunately, fortunately. But I think where it's a patient who's anticipated to pace more than 40%, their ejection fraction's less than 50%, no indication for a defibrillator on the surface of things, I would also advise a CRT pacemaker.
Yeah, I think that's what this patient would get at our center, more than likely is a CRT pacemaker. It also allows you to sort of watch them going forward in terms of electrograms if they have other arrhythmias or other things. So this one I think is reasonable.
If she'd had syncope, it would have been a harder question, right? Because then was it bradymediated syncope? Was it non-ischemic cardiomyopathy, ventricular arrhythmia-mediated syncope? I think that becomes a harder question. But thank you for not making it harder.
Right, there you go. So this was a case, Chuck, of a patient who has complete heart block and has an EF of like 45%, and came in with dizziness with complete heart block. And what kind of device would you implant?
There's a question over here.
Sorry.
Oh, sorry.
So I just have a question about cardiac MRI and risk stratifying patients with non-ischemic dilated cardiomyopathy. I know that there was just a recent paper from DeMarco that talks about how late gadolinium enhancement in these patients actually is a better risk stratification for EF. And so I'm wondering if you utilize cardiac MRI or other advanced imaging techniques to help risk stratify these patients to determine what device to put in.
So that's a really great question. So you have a non-ischemic heart disease. Is this going to get better, or is there a scar that could put the patient at risk? And particularly if they had syncope, it might have ventricular arrhythmias. And what do people do? Are you doing MRIs in these patients?
Maybe I'll answer a different way. There are certain cardiomyopathies which are known to be more arrhythmic, that people might be more aggressive. I don't know, Dr. McIntyre, do you want to weigh in? But maybe Lamin would be one example. So we might not be as strict. Is that probably
Yeah, no,
true
it's
of
fair.
the
So
EF?
like laminin AC cardiomyopathy, I do worry more at a higher ejection fraction, similar with some of the DSP-mediated, more inflammatory cardiomyopathies, especially if there's circumferential late gadolinium enhancement, the risk of sudden death seems to be significantly higher. So I do think understanding the underlying root cause for their problem is important. One of the problems is oftentimes they haven't had a complete workup when they're showing up like this, and you can get the MRI, but you won't know what their genetic mutation is. Those sorts of factors can be really tricky. It helps that she's still alive in her 70s and hasn't had a sudden death event up to that point. So, we're probably dealing with not a super high risk substrate. But
And then in terms of non-genetic, sarcoid would be the other example. I know you talk about it. You probably would go ICD as well, right? Or CRTD. So there are certain circumstances, even if the EF is higher than the usual 35%, we probably would go generally to ICD tachytherapy.
And we do that with sarcoid also. And if you look in the appropriate use document, it does go into the different disease processes too.
I just,
How long is, which button? No, okay, sorry. I just wanted to emphasize that point that often the patient comes in with complete heart block and you say, well, we got to get him on the schedule. But then there's never been an evaluation. But there have been, it's not in West Coast a real common disease, but every year there are a handful of cases of sarcoid I diagnose in people who came in, got pacemakers for heart block.
Yep.
And there's, and then the question is, you don't want to keep, particularly in people who are pacemaker dependent, you really don't want to be leaving them with temporary pacemakers longer than necessary, but you do want to have that consideration. They have ventricular arrhythmias, you can find a way to get a pyrophosphate, to get an MRI or, a PET or a FDG PET or some kind of test. So you have patients with temporary pacemakers who can't really do MR scans, but it saves you a lot of device revision.
And kind of like we talked about yesterday, you may not have a lot of Lyme disease in your particular geographic locations, but many places in the US, Canada do. So it's good to know where your patient's coming from, because if it's Lyme, maybe they don't need anything. Maybe they need antibiotics. So I do think that doing the appropriate workup and worrying a little bit less about how quickly you can get them on the table in the EP lab is worthwhile, because you want to do the right thing for the patient.
Mm-hmm.
So recently, I saw a patient who wanted the tachytherapy to be turned off because the ejection fraction normalized and she hasn't had a shock. It was for primary prevention. One other patient during gen change asked that the ICD was replaced with a pacemaker. Would it be unreasonable for a physician to suggesting turning off tachytherapy, or for example, like the first question where we recommended an ICD after revascularization because the patient required pacing after CABG. If the ejection fraction completely normalized, would it be unreasonable from a physician to recommend turning off tachytherapy just to avoid inappropriate shocks, or is the percentage of inappropriate shock very, very low? It's unreasonable to make such a recommendation.
Yeah, and so where that scenario comes up a lot is someone had a CRT ICD, their EF normalized over time, they're coming for their generator change. So do you downgrade it, per se, to a CRT pacer? What do you guys all think?
Yeah, I think it's a great question. I have to tell you, in my practice, I never downgrade. I think, I never recommend downgrading, let's put it that way. I think if the patient decides to do that, that's great. We usually try to lightly discuss it, saying, oh, you could get this, but I'm not recommending that, So I think it's a great question. I think it is, what you're suggesting is totally plausible. I would just have to say that's not what I do.
It's also a hard question when they have DF4 leads, right? Like are you going to add in a new pace?
Very, very good point. In the current era, that's right. You'd have to reimplant another lead to downgrade them, which is like that.
It's probably a higher risk procedure.
I'd probably say stay with the ICD lead.
I think in certain scenarios, I agree with Paul. I think that taking away something is a little bit harder, and you suggesting it, even if they've had bypass, then you've got substrate, they've got coronary disease, they had a decreased EF for a while. I mean, it's just a hard one to sort of swallow. The one that more commonly, I think, is the non-ischemic CRT, who's a super responder. That one, I think, might be more reasonable to go pacemaker. But again, the issue becomes DF4 versus not. And so in general, there's a lot of inertia, and in general, I'd say we don't generally do that as much.
And getting into the conversation too from last night with Dr. Sears, at least when someone has suggested that to a patient, and they'll say, but they feel safe, they feel comfortable with their ICD, and the data. I usually, for that scenario, I would not do either. I wouldn't, down. And if we use the word downgrade, that kind of sounds like a negative term anyway, to the patient.
But you can turn off tachytherapies.
You can turn off.
Right. So I think the reasons to consider it are, first of all, what's the odds a patient's going to get an inappropriate therapy? Patient has a reliable lead. They've had the device in for umpteen years. They haven't had inappropriate therapy for a long time. The chance they don't have AF with our, their AV conduction is weak. The chance is really small. If somebody brings that up, you can reassure them that the probability is low. Let's say the probability is high, or let's say somebody's developed cancer and they're elderly and they've had their pacemaker, their defibrillator for 20 years, So whether it's a effective downgrade by programming or, put a different device in at the time of generator change, I think, there are elderly people who say, I like who are willing to bring up that conversation and have that conversation, and I think that's important. And I also agree with Amin that in young people with normal MRIs and cardiomyopathy and pure left bundle who respond perfectly, I think there's a good argument that those aren't patients with a primary cardiomyopathy and, quote, super responders. Those are people with left bundle branch block induced cardiomyopathy in the same way we have pacing induced cardiomyopathy. And what they need is the right pacing system. So I think it's important to ask that question at the get-go and when we start with those patients, right?
And in my world, making sure that the device was put in for a good reason in the first place. So, I deal with channelopathy patients, and a lot of the ones that come to clinic, we never would have implanted a defibrillator in the first place. So when you're looking at a generator change, should they have had a device at the get-go is a really important question, because committing a 20-year-old to an ICD for the next, 70 years is a big question.
Yeah, great points. Oh, yes.
Hey, guys. So in this question, the individual certainly had an indication for pacemaking. But I guess with the reduced EF, who are the folks that y'all are bringing back and thinking about an EP study to see if there is inducible VT or VF? This person didn't have any documented NSVT, but then again, sometimes, she has dizziness and you haven't had a chance to prescribe a monitor. Just kind of thinking about that calculus, who's do you think about for EP studies?
Yeah, that's a great question. So you have, that EF. So this is a non-ischemic cardiomyopathy, cath normal coronary. So the value of EP testing in that group is not so great, chance of having inducibility. We used to do so many EP studies years ago, right? But now, with the studies that have been done in the interim, if, they have that, I guess, ischemic myopathy, 36 to 40% is how many of those patients are there, right? You could say non-sustained VT, and if they have inducible VT like must, that would meet criteria for an ICD. I'm curious, what do other people think?
I think you should accept the obvious. A patient gets a little dizzy with complete heart block, that's the problem. You have to practice medicine in real life, and I think you move on. You got other things to do during your day.
Okay, great. All right, so yeah, there we go. And then this is just showing you some of the data, because I gave you that mid-range, EF. They didn't meet criteria for an ICD at 45%. And so where does that data come from, and is there a guideline to address that? So, Block HF was the one study I wanted to just point out and they had, these are patients who had indications for pacing with heart block. They have heart block and they have, some heart failure. EF of 50% or less was the cutoff. And if they had an indication for an ICD, meaning they're probably 35% or less, or another indication for for an ICD. Maybe they had, sustained arrhythmia or whatever it was. But, they were assigned to either standard RV pacing or bi-V pacing. So that was randomized. And after, in follow-up here, you could see that those who received the bi-V pacing did better than those who received RV pacing. We do know, we talked about yesterday, adverse effects of RV pacing and dyssynchrony, and they had a lower incidence of the primary outcome that was outlined there, which was time to death from any cause, urgent care visit for heart failure that required IV therapy, or 15% or more increase in LV end systolic volume. I think, this is one of, well done, a study, is one of the indications probably in our guidelines. I think, not everyone, I don't think I see everyone getting an ICD for this, of this, getting a CRT for this indication per se, because I think people focus more on the 35% or less, but in the guidelines, it's not a class 1 recommendation, not a level of A, it's not multiple randomized studies, it really hasn't been reproduced in that regard, but patients who have AV block, an indication for permanent pacing, our patient clearly did with complete heart block, and the EF is between that in-between range, doesn't meet criteria, for CRT, yet, but because it's at 36 to 50%, and they're expected to require pacing more than 40% of the time, which is, clearly was brought up initially in the discussion. Complete heart block is going to be pretty much all the time, right? It's reasonable to choose pacing methods that maintain physiologic ventricular activation, which was CRT, we have most data on. And actually, in the guidelines, and this was back in 2019, there's a new document coming out within, certainly less than a year, looking at, indications. And so HIS bundle pacing was in this despite the absence of randomized studies, but at the time, right? And now probably is going to comment more about, left bundle area pacing in the updated document. So basically met CRT indication based on the block HF type of criteria and the frequent need for pacing despite the EF being, over 35%. And I think that's all I had.
Yeah, great.
So,
Thank you. Yeah. Great. I think we're ready to do our breakouts, right? Is that correct?
We have an unexpected, something new, not on the agenda, a little surprise. And I wanted to invite our lead design leader, Eric, to give away 2 prizes to those that everybody was super successful. And he has 2 that he wanted to give. So I'll let you pass it on.
Oh, with lead design.
Lead design.
Awesome.
Hey. Well, again, good morning. I know it's not on the agenda, but at least some of you really suffered between the day before yesterday, and then earlier this morning. But we had to choose, 2 winners. So the winner goes, Jorge. Where is Jorge? Jorge, yes. Congratulations. You made it on the top, so I recruit you officially.
Yes, you have a new job.
You have a new job. Yes, you do. Come on.
EP is not good.
Congratulations.
I can go to Puerto Rico.
Congratulations.
Oh, wow. Thank you so much.
You're welcome.
Thank you, guys.
And then the number 2 was difficult because number 2 we had to obviously like a tie, and we had to make a very difficult decision because even though the number is the same, but we're looking also at consistency between operations. So number 2 is Kate. So Kate, congratulations. You're also welcome to join us. And we'll make leads for babies.
Thank you.
I know. Congratulations. Congratulations.
Thank you.
Sorry for the interruptions. I hope you enjoyed the experience. I know it's difficult to squeeze. I wish I could have like 3 hours with each and every one of you to show you all the tips and tricks and the secret of the polymers and the material and the testing. But hopefully, lesson learned for the next time. We'll have more time. I hope you will. All my best.
Thank you.
So we're going to go to breakouts next, and we'll have 3 sessions for this. So there's one more thing that I forgot we got to do. So we'll do our
And then, do they know which slides to put up? Oh, there you go. Yep.
Yeah, one of
Okay, hello everyone again. So we're going to look at cases that are related to chest X-rays mostly in radiography. Okay, so this is a 60-year-old male with a non-ischemic cardiomyopathy, had a primary prevention ICD 2 weeks ago. Could you put the timer on too, just so I know? I think it's a 40-minute session, or? Yeah, thank you. So a non-ischemic cardiomyopathy, had a primary prevention ICD 2 weeks ago, presented to the office for a wound check. The device interrogation was performed, and I'm going to show you the chest X-ray in a bit, but let's look through the device interrogation here. Not sure which screen is easier to see. So here, you can see, obviously it's a recent device, the battery's fine. Here are your impedance values up here. Here's the shock impedance on the RV lead. Here is, some capture thresholds are shown here. And then here's your P wave and your R wave. And here's how the device is programmed. So it's MVPR mode. Lower rate, upper rates are here, and then you have some discriminators on and stuff. And let me show you the chest X-ray. And I know this is reality, and you probably can't see anything from there, I'm sure, and I'm going to blow up a couple of things here. So you're looking at a chest X-ray, there's a big heart, it's like almost impossible to even see the leads. And I am going to tell you that the lead is in good position because you can't see it. But I'm going to show you something else blown up. So you saw, I think, something in particular stand out at the interrogation. Anything kind of pop at you? So high impedance in the atrium. Okay, good. Threshold was also a bit up right there. So I'm showing you things as where you might see a problem, right? And this. And I know, and feel free if you want to look closer, but there's two things I'm showing you that are going to kind of go along with the answers here. And the nice thing on Epic or whatever you use, you could blow up things and try to look closer, and that's what we're doing here. So would you recommend atrial lead revision for fracture, generator replacement for pulse generator failure, reoperation for assessment of the set screw, or continued observation? So what things do you think about if you see that kind of finding early after implant? So you think set screw. And can that really happen nowadays, or do people they're not so careful, or I've seen it, right? Yes.
You don't want to be the person that caused it.
Right.
Usually a fellow does it.
Yeah, I think it's the attending's fault all the time, no matter what. And I think the fellows are more careful sometimes. Right.
You see it? No,
And the attending's going to rush to in multiple cases when they're not with the fellows. So, it's okay. So, can you get a fracture, or so early? I mean, to fracture a lead that early would be pretty tough. I mean, if you tie onto the insulation really tightly, I guess you could do something to the insulation. What would you guys recommend? Yeah, I'd put my money on that too, because it's so early after implant, and other things, you may not see some problems so easily on your chest x-ray. Fractures, sometimes you see, sometimes you don't see. So that is the answer, and this is my partner. I didn't actually do this case, fortunately, but that chest X-ray, and you have to look really, really closely. The one thing I really like with the Medtronic devices, actually the ICDs, is they have that little blue tip, that little blue tip that you can clearly see it, because sometimes I push it in and out. Am I really seeing it moving through? That kind of thing. But that little blue tip tells you you're definitely through, the area of the screw. So this is you took out of the pocket and took a picture of it. So if you look, I think you could see it from where you are. Can you see that he just took it out of the pocket before doing anything. The top one doesn't have the little screw through the end of it, and the bottom one does. And that is one thing you could see on your chest x-ray. This is really, truly one thing we never want to see, because it is preventable, right? And then one of the things you could do is right after the implant, you could do an interrogation. It's better to know right there where you're still in the room and the patient's still prepped. But you could be careful first of all, but you can do it right in the room before the patient leaves, and know pretty quickly in most cases. Has anyone ever seen a loose set screw clinically? We always talk about it. Yeah, we had one other in our QA process. Out of all the years I was at Penn doing QA, and all the years I only saw one other one of these. And it's usually on a super busy day, everyone's stressed and rushing, and just somehow the device doesn't get interrogated immediately, and also people are just rushing to put it in. But it is something that's preventable. Yes.
This device interrogation reminds me of a guy I'm working up that we thought that his atrial lead potentially had perforated through the appendage, but now I'm thinking set screw. I'm curious. But his impedance trends have quickly, not suddenly, but quickly gone high.
Huh.
How would this present? Would it be just impedances dramatically high immediately?
Yeah, that's a good question. So, would it happen right in the lab, or would it happen a couple of days later? I guess you could say, I think it's pretty quick. Would it be after he starts moving around, or would you see it even before he starts moving around? Yeah, that's a good point. And the other thing too is, those of us who have a little OCD, a little obsessive compulsive, you could, in the lab after you screw it in, you could kind of pull back and relook, and those kind of things. But yeah, so I think it would be pretty quick. Any other questions? Okay, this is just a quickie. So where is this RV lead? Is it in the outflow tract, the left atrium, or the CS? Right, there you got that. So I think, and this is not, all that uncommon. I know we saw a couple of cases, the other day. This is actually one of the same films. But, just to kind of know, what you're looking at on the AP view or a PA view here is it crosses a little bit lower than you'd expect it to cross on the valve. Usually it cross up here, and it gives you that CS, kind of appearance is, in that AV groove. If you could see a fat pad, which you can't see on the x-ray, you can get an idea. But if it's in real time, in motion in the lab, you could see sometimes that rocking motion looking like the CS. And after you see a few of them, you kind of get a feeling. We talked about ways to prevent that. What are some ways to prevent that potentially? Look in LAO, so before you leave, and if you look in your LAO, and this was the one that was implanted by a surgeon somewhere else, but even with portable fluoro, you can get a little LAO to see if you're really posterior and you're in the CS. So you can look LAO. What else do some people do? Right, put it into the RVOT, and then you're in the RV because you're getting these PVCs, and so you feel more comfortable you're across the AV valve and not in the CS. And what's the third thing? So you see ectopy. You'll see ectopy in the outflow when you're in the RV, and you can see also the amplitude. Sometimes the amplitude of the V isn't as big, but sometimes you could have a reasonable, V. And some people, routinely prolapse, and we talked a little bit about that. But some people, prolapse it in the RV to begin with. I don't. I don't know if other people are. How many people prolapse it routinely? I actually had a curiosity to get into the RV. So not so a couple people, but not universal. Yeah. Okay. Right. So good point. So you can look at the signal. Now, often when you're the implanter, so people are not necessarily showing you the signal. So then we're relying on whoever's looking at that signal. So that's actually a great idea, to actually put it up on your monitor, so you see all your blood pressure and your EKGs and all that stuff during the cases. I like that idea, actually.
You can see your own current of injury. You can see if your airway is staying stable. It's really nice to have that feedback.
I like that. Yeah, so just a cable directly from the programmer, is that from the? Yeah, that's a nice idea. I'm gonna start that. Okay.
I have a question.
Oh yes.
In order to know that's not actually the left atrium radiographically, is that because if it's going through a PFO, it would be like crossing higher. Is that how we know?
Exactly. So if you're going through a PFO, and that is a possibility, right? You can cross through a PFO in some of these cases. Potentially, you'll still see you'll see a great atrial electrogram, and then hopefully, when someone's checking pacing threshold, it would be obvious that you're pacing the atrium and not the ventricle. But we've seen lots of things, and I think I have one case coming up. But it's you would cross over much higher. Yeah, and then you might not have that. You wouldn't have that same curve. Chances are you wouldn't curve that much in the atrium. Okay, so this is a 38-year-old female with long QT syndrome, recommended to undergo ICD implantation for secondary prevention after a VF arrest. I guess this would be one of the indicated channelopathy ones, in a patient had a cardiac arrest.
Controversial, but yes.
I know, it's like, my Ackerman does it. I always thinks that we should never put ICDs in, you guys. So controversially, would a VF arrest?
For long QT1, it's a little controversial now, because if you're undiagnosed, untreated, and beta blockers work so well, but you still do it, so you can still consider cardiac arrest to be an indication. But there's debate.
Say that's, because we have much more effective therapies and ways to treat these patients now, right? Or to know that the evidence isn't, as strong as maybe we thought. What if she was on a beta blocker already?
Then beta blocker, like Nadolol at a real dose, then you definitely would. I would do a defibrillator in that context. Not as great.
And that's a fake dose, right? That's
a little bit fake.
Yeah.
It's not horrible.
What do you usually get them up to it?
So in my high-risk patients, honestly, 40 to Sorry. So in my high-risk patients, like if you look at the guidelines, it says 1 to 1.5 milligrams per kilogram per day of Nadolol. So 40 to 60 milligrams daily if it's long QT1 in the morning, because their events tend to be in, daytime adrenaline type situations. If it's long QT type 2, I dose them at bedtime. So there's some nuances to the treatment. And depending, their genotype actually does matter in terms of other treatments. So mexiletine, intentional atrial pacing. There's a lot of other components depending on what their genotype is for treatment. But I wouldn't worry too much about a defibrillator in a secondary prevention post-arrest situation. I think it's a good thing.
Great. So we can get a lot of other information into these cases too, besides the device. Physical exam is pretty, unremarkable. QT is 490 milliseconds in sinus rhythm. So what happened here? Yeah. So the patient. So I think there's something missing here. This is weird. So the patient elected a sub-Q ICD. With the sub-Q ICD, if you're putting it in, make sure you pass screening, especially in someone with long QT or with other processes like bundle branch block. You want to make sure that it fits into the template. Now, pretty much the reps will be doing this for you, and it's done on the programmer now. But you want to make sure that the sensing is going to be appropriate. You don't want to get you don't want them to have inappropriate therapy. So then, again, if you're doing DFT testing, for sub-Q ICD right now is sort of recommended still. You would, do that in the lab and induce VF, and unfortunately, this isn't working. So the patient, is even at 80 joules, the maximum output of the device required external rescue. And this is the chest x-ray or fluoroscopy, hopefully if you realized, in the lab. What would you do here with the subcutaneous ICD? Again, we didn't talk about this kind of device, so I thought I had to throw a case of this in, because you will see them at your center. So you move the can lower and retest now. Move the shock coil closer to the sternum, and this is the shock coil, here's the can, and retest. Leave the system as is and retest tomorrow. Remove the SICD and implant a transvenous system. What would you do? And I don't think we have the audience response, so just yell out. So someone said move the shock coil, and someone else said move the can. And then was there another one? Yeah, and that's actually, so the can actually is in a reasonable position. You want it to be across from the coil. You want it to be close to the chest wall. This is not a heavy patient. And you want it to be not too low, because if you move it too low, you have the diaphragm, you're not in the right vector with the heart. And this is a little far over to the left, so there's, maybe less ideal vector. So, we would normally, in this particular system, move it closer, and then, 65 joules worked on 2 occasions after moving it over. And there are, there's different criteria and there's different things to look at. So either the lead could be too far from the sternum. There's lots of things that can go wrong. That's why I think if you're not used to implanting these, you should do a defibrillation check. The generator, I think the more common problem I've seen elsewhere is that the generator should really not be anterior. You want it to be really in that mid-axillary line. You don't want it to be anterior like this. You want it to be the lead where it's tunneled to. So here, the lead, if they're an obese patient, there could be a lot of fat. You don't want fat in between the lead and the sternum. You want it to be right on the sternum when you tunnel that. So you also don't want the pulse generator to be too low. That's the other possibility. So lots of things can impact on defibrillation threshold. And then this is here, and you can measure a high, someone asked yesterday actually, could you just use high voltage impedance? And the chances, if you have an impedance being over 100, the chance of that being a high defibrillation threshold is going to go way up. And often it could be the fat, it creates resistance, and it's not, shouldn't be between either. Here, you can see fat in between here. This is right on the sternum. That's what you want. And there also shouldn't be fat between the can and the chest wall, and many people are probably most of the time now we stick it in between the muscle, just to it hurts a little more, as the only negative afterwards, but you want it to be at least right onto the chest wall, and do stick a little, I don't know if people routinely put a little suture into the can. This, you really need to do that because you don't want it to fall down. It's heavy. Even pectoral devices, I actually always do that too because they can move, and I think it also keeps the leads nicely under the can, so when someone does a generator replacement later, it kind of holds it not too tight because you want it to fall in a comfortable spot, but you don't want it to sag, especially in the little old patients that have not a lot of strong tissue in there. And so this one here, this is the optimal placement of the lead here and the device here. A nice vector. Any questions on that? How many people implant SICDs in this room? Oh, a good number. Okay, so that's, do you get a good number of cases, or is it a rare case here and there?
Once a month.
Once a month?
Yeah, fairly rare.
Okay. Is it mostly that niche population renal failure kind of thing, or young people? Okay. Prior transvenous infection, that kind of patient too, or? Okay, I'm just curious.
Can I make one comment about long QT syndrome?
Yes.
So most long QT syndrome patients getting defibrillators are younger, right? So there's often this pressure to put in subcutaneous devices. For long QT2 in particular, atrial pacing at an increased rate shortens the QTC, and they have a significantly lower event rate, which you're not going to get with a subcutaneous ICD. And the other issue is that if you do ECGs on people twice a day or every day, you're going to get dramatic variability in what their QTC is and the amplitude of their T waves. So just because they screen in once in clinic doesn't mean they necessarily will. So it is a concern as well in terms of their risk of inappropriate shocks, which, especially for long QT1 or CPVT, inappropriate shocks can kill them because of the adrenaline surge that it causes and cause a shock storm. So it's just important to not just think about the vascular access issues and think about the substrate that you're treating too with these patients.
I think that's a great point. So, you want to be able to reduce the arrhythmia occurrence. You might want to have them on a higher dose beta blocker because this was not a real dose, as we heard. So you want to be able to do all those things. And then, some of these patients, and with somewhat long QT, I would get up on a treadmill, or the same thing with the hypertrophic cardiomyopathy patients. Sometimes they have big T waves. That you want to make sure they're not going to get inappropriate therapy, because these young people can really increase their heart rate pretty significantly with exercise too, and that's where you get into more problems because your heart rate's faster, and then you double count your T wave, and then you're in trouble. So I think that's a really good point. This one was really a long QT patient, but maybe I'll change that case next year. No, I just kidding. So there's other things to think of is a really important point. So this is a 56-year-old who has a history of dizziness and sinus pauses, had a pacemaker, and so the other point is to make too is younger people are more at risk of lead problems. So if they're doing a lot of things with their arms, and cosmetically, you could see it more here, but it's maybe a bigger device here, but well concealed. So this, a lot of these, decisions that are hard, it should be thought of, right? And potentially shared decision making, but we should be making recommendations, particularly about the medical type of, issues like suppressing arrhythmias or preventing arrhythmias. So anyway, 56-year-old with dizziness and sinus pauses, had a pacemaker 3 months ago, now complains of recurrent dizziness. What should be considered? And failure. So I don't know how well you could see this because to me it doesn't project that well. Can you see? You got it. You could see. So your eyes are really good. So you could see that. So would you say failure of the atrial and ventricular active fixation mechanisms? Atrial and ventricular lead lengths chosen were too short, or potential Twither syndrome? So I couldn't hear you.
It's either like a wheel or a ratchet because they're so well coiled.
Yeah. Yeah, so it could be so it could be, and we used to, so that's actually a really good point. So we used to always blame the patient for twiddling, but there's, a couple of, reports in one paper actually I reviewed, but looking at, some other things and the way you torque your lead and how you put it in and how, the two leads, because if it's more than one lead and two leads together, what is the mechanism of that? Do we blame the patient or do we blame the implanter? I think that, and that's the other thing too, I put the suture in there too, because I think it's harder for them to, not that I think most patients do, twiddle it, but that's always a possibility. So I didn't give you that choice, but that's a really good point. So.
Anchor or no anchor on the Gen
So I do anchor, not only do I, go around the suture sleeve for both the atrial and the ventricular leads, and I put 2 on both of them, and when I sew, I think the other thing too is you want to make sure that suture stays for good, right? It's a non-absorbable suture, so whether you use silk or some other type of suture, I go into the muscle and then I tie it to the muscle, but I don't tie it tightly. Like, you have one, a little bit of a, something you can still stick something underneath it because you don't want to necrose the muscle. If you tie too tightly to the muscle, you'll necrose the muscle and that suture won't be there in a few weeks. So you want to tie tight enough that, but you want to give it a little breathing room. And then I tie around the suture sleeve, and I do that twice on each lead. CRT, I'll do 3, but it's just to know that you have a good give. You can tie tightly on the lead if you have the suture sleeve over it. If you don't, and even if you're in the cephalic, I'll push that suture sleeve in the cephalic and tie over. You want to make sure that you're getting tightly enough. And then I pull the stylet out before putting the second tie on because the lumen does take up a little bit of the distance, and there's some theoretical thought that if you leave that suture, you could still probably pull it out, maybe a little harder to pull out with tight sutures around the suture sleeve, but take one out before putting especially on the smaller lumen leads like the CS lead, take that other stylet out before putting that other suture on. So I do put them on the suture sleeves, but then I do put it on the can still. But it's a little looser on the can, so it has some motion, but not too much motion that it'll fall really low. Did I answer that question, what you were asking? Okay. And so this is a different patient, but this one's a little more dramatic, that I think is, more clearly Twiddler syndrome, but I mean, I had never seen anything kind of like that. I mean, that is like really knotted on that case. I didn't show you that one because the arrows were pointing. Anyway, anyone see Twiddler's cases or?
They're horrible.
Yeah.
But
okay.
it's really, but taking them out can be really hard, especially if they've formed capsule at that point. But it's impressive. Really twisted.
I've seen a sub-Q ratchet.
Oh yeah.
Yeah. And they used they didn't tie down the suture sleeve well enough, so the impedance was super low and the lead was pretty much right next to the can. So,
Yeah. Yeah, that's interesting. Actually, neither of these 2 cases were mine, but so I don't know the specifics of whether it tied down the can.
Is this something that we should be counseling our patients on? Like, I guess I don't think
They never say that they touch their device. Like, if you ask them if they had been playing for it, the answer is 100% of the time no.
Right.
That's my experience anyway. And then
Yeah.
you're looking at that, and you know that you didn't, or whoever playing
You didn't leave it.
put in that way.
Right, you didn't leave it that way. But yeah, they always say no. And I do tell them now, though, with implantable loops, don't play with it. Don't touch it. Don't play with it. Don't push it, even if it itches. Okay, so what would you expect to find on pacemaker interrogation here? High atrial impedance? Did you guys want to say something else to the audience, or if you can? I'm sorry, I didn't mean to cut you off. Oh yeah, loop. So yeah, yes. I don't know. I never used to put the little suture in, but now I do. Just one little quick one. But anyway, yeah. And because there were a couple of cases of that were shown here. So what would you expect? A high atrial lead impedance and normal atrial pacing threshold, or low ventricular lead impedance? Yeah, good pickup. So it's like, most of the time you just don't see anything on your X-ray, right? We do them, but then you just don't see it. So yes, I blew it up there, and it's like totally like disconnected. I think this is the only film I have, at least, that has that kind of really dramatic. I guess the pointer doesn't work anymore, but I think you could. I can't really see the pointer, but anyway, I think you could see that nothing's afterwards. It's kind of completely decapitated there. Okay. So that would give you what? High atrial pacing threshold. And probably with that, you're not going to get much atrial pacing, right? Okay. And so this one I put in, this is a pacing system. So just tell me if it's true or false. This pacing system is most useful for patients with sick sinus syndrome who are bradycardic at rest. True or false? False. And why? I'm sorry, I can't hear you.
Is it the Medtronic?
It is. Right. So, with a bipolar electrode, and was brought up, I think Tina or someone brought up yesterday, it's nice to actually have it for sensing, and it might be nice to have for diagnostics for, AFib. And sometimes, actually, if you look at the original data, from the lead, you could see that it actually does capture, the atrium. And these leads used to be around, but I've never put one of these in. But I don't really use Medtronic devices personally. Not that because they're bad devices. It's just that it's not on our contracts anyway. But basically, you're not going to be using it for pacing. You get atrial synchronous ventricular pacing, but for sick sinus syndrome, you're putting the pacemaker in for sick sinus syndrome. It's kind of hard not to put an atrial lead in. All right, so this is a 66-year-old with sick sinus syndrome. Pacemaker 2 days ago complains of chest soreness with deep breathing as well as a jumping sensation felt in her left lower chest when sitting upright. The rhythm strip shows atrial pacing with intrinsic conduction. These are her numbers, P waves 2.1, R waves are 2.9, and the impedance values are shown there, and the thresholds are shown there. You would recommend reprogramming the device to lower the ventricular pacing output as much as possible. Maybe you'll get less of that jumping. Turn off the RV lead as the patient only atrial paces. And actually in Canada, you do AI pacemakers, right?
Not as much as people think we do.
Yeah, no, that's not true. Okay.
We do, but not as much.
And it goes to show you that we do it because we have it, the technology. No one kind of thinks of the additional cost per se, but it's there, and about supposedly about 50% of patients could develop AV conduction disease. Although would that really require a pacemaker down the line, especially now that we even use MVP modes, is also in question. But separate topic. Would you recommend lead revision or continued observation? I'm sorry, say it again. Let me just say that it is, less than 1%. So that would be, not an unreasonable thing. I should have told you that. So, lead revision, why? Yeah, absolutely. So that's exactly true. So this lead is outside the heart, and actually, let me see if can't remember if this case has something afterwards. Oh, yes, it was perforated. And I didn't have a CT scan on that one. That one had an echo. I don't remember specifically if they had a little effusion or not, but it was clearly, outside the heart. And then this here, you get another kind of appearance. And I think again, and again, it's so hard. I'm so sorry. It's hard to see on this screen, but your eyes are always better than mine here. But it looks like it crosses, right about here, and then it points up. It's kind of a funny position, right? And this one did have a CT scan, and you could see it's, through. And sometimes it's more subtle. You just get a little piece of the screw that's through, but sometimes it's not so subtle. And this patient did have an effusion too. Okay. Now, this is also a real, I mean, these are real cases, I didn't really make up any of the history on any of them, but this one's hard to believe. But a 54-year-old woman with coronary disease, ischemic cardiomyopathy, syncope, inducible sustained VT, had an ICD. It's an older case, but routine follow-up performed elsewhere, and we do see, a good number of practices, the private practices more than the university practices in the US, that might follow their own devices. And they have a rep come to the office, and usually the reps are terrific, or they'll have one of their own staff, if they've been trained to do, the pacer evaluations, and they bill for them. And so, the reality of the US is a little different than, some other places, but they do this and they follow them. So it was 3 years ago since the implant, and had stable pacing threshold and sensing were reported. We follow the patient every 3 months at this point in time. Everything's been great for years. Aborted shocks were now noted without symptoms. And this was, I apologize for the quality of the tracing, but this is what one of them looked like. So it's just a single chamber device. And this was the real-time electrograms. Kind of hard to totally know what you're seeing, but anything look a little funny on the bottom one, or? And the top is the rate sensing channel, the bottom one is the shock channel. Maybe you see, kind of a double signal there of some sort, but let me show you the aborted shock. Again, onset of arrhythmia, of some sort detected here, and then that was the shock. And they got back to sinus rhythm after that. So this is the real-time evaluation in the office. So you have the top tracing actors, I think, is a surface lead. And the bottom one is the actual device, in CAN, it looks like CAN to system there. And you can see that single chamber device. And this is the pacing threshold done in the office. And it was low. They're right, low threshold. So what is the most likely reason for the aborted shock? So here's the rest of the interrogation. Impedance, is a little bit on the low side maybe. You have some really short VV intervals. And that was what that looked like. Is it from non-sustained VT, oversensing of noise due to an insulation break, oversensing of noise due to fracture, or atrial tachycardia? Okay, so why is that? Right, is that wild? So this is not something that happened overnight. So here you only have one signal, and yes, the heart rate gets faster when you pace, but that signal, is pacing the atrium. In fact, you can even see on the bottom one there, you can see even a little P wave on the electrogram, suggesting, maybe you could be just barely across the AV valve, but clearly you're pacing the atrium, and this is not something that would just, likely have happened overnight, but it was stable. So it is an atrial tachycardia, so that lead was in the atrium, and this is what it looked like. And, this is, pretty twisted around there. It was dual coil lead too, so it was pulled back probably, relatively early after implant. And then, it's still although they may say no, what other question would you ask them about their history? How to get twisted, maybe, maybe that's a reason. It was just really twisted. I've never seen a coil twisted like this. I don't know if anyone else has, but it was amazing. And now it's, years later, right? So what would you do next? Revise, yeah. So maybe is that going to be easy or not, do we think? So she had an echo, her EF is getting a little bit better, no effusion, the lead motion on TEE, because we were concerned, where exactly is that lead? It did, we couldn't really tell, was it stuck to the valve apparatus or not? Probably not, but we couldn't tell. The CT of the chest, looks like the lead's only in the right atrium without any attachment to the valve, and so my partner tried to take it out, but the lead was so twisted, even after retracting the screw, that actually the patient required a surgical intervention. So maybe if it'd been picked up early, this would not have been the case. Okay.
Have just abandoned it, put in a different ICD.
Yeah, so that would be, would anyone have abandoned that and just put a different ICD lead in?
Because sometimes we do just like, we don't always go straight to extraction where I'm at. If it's still open and patent, we'll put an extra lead in and abandon the other lead. So
And
it happens,
And I think that happens a lot. I think that, that a lot of places would do that. So first of all, most places in the country don't even have an extractor on board, right? You'd have to send them somewhere else. And so I think that your threshold to try to extract something goes way down when the person's right there. It's just the reality of life if you don't have the resources or So I guess, to me, the lead was so twisted around. And if you had an infection down the line, is that, now if just 3 years or whatever it was, if it's 10 years, what are we talking about? I guess they'd still go to surgery. Yeah, I think you could consider that. I mean, what would you do? Would you?
I'd worry a lot about it, but I think it becomes kind of take it out now, take it out later, that debate, looking at other patient factors, what the potential risk of a surgical intervention is now versus later. And you didn't know that you wouldn't be able to get it out until you couldn't get it out. So, I think it's always that question of when you intervene, if you intervene, and it's not a simple answer. So I probably would have asked somebody to try, and then have a very good discussion with the patient if that failed.
Yeah, and the surgeons didn't seem to have, much problem.
Yeah.
With, they're right there looking at it. I guess it's a little different scenario, but
You'd be more worried about how you keep it from happening again, right?
Right. All right. Thank you. I think we're right on time, right? Oh, we have 10 minutes. Okay, so do you guys want a break or you want to talk about anything else? Anyone want to check out or something like that? Yeah, oh, that would be really fun.
Oh my God. Can I start now? Okay, cool. All right, let's see here. Wow, it's loud. Clickers here. Okay, great. All right, we'll get started. How are you all doing? You're doing okay? You're hanging in there? Okay. All right, great. So this is really designed to give you a systematic approach to programming CRT devices. And particularly, I came up with I call it a 10-step method. And these are the steps that you can go through and kind of systematically use. So that's the purpose of this. So we're going to start by asking, well, how do you tell when people are responder or not responder, right? So what are the different kind of ways to look at our goals? So I think pretty much the thing that stood the test of time is remodeling, right? That's the critical linchpin of CRT. And so of all the indices that we can use, what's held up the best in the literature? And it's end systolic volume. So that gives you the best idea of what's happening in terms of remodeling that you can kind of rely on. And most of the literature uses ESV as the index, okay? So that's what we generally use. And as a result, as kind of I mentioned here, the people who have a decrease in end systolic volume do really well. The people who have further dilation do really, really poorly. And so it does seem to go with other outcomes as well. So that's kind of the principle. Now, what do we think about in real practice? Is that what we do? Is there something else we do, et cetera? So it's much more of a composite probably in your daily practice. So not only is it these measurements like ESV, but you'll include symptoms, ejection fraction, et cetera. So the things that I've listed here. And then we'll talk about non-cardiovascular kind of causes in a moment. So when we think about this, what's the different framework? So this is one framework that I go back to. It's rather old, but it's really kind of where we started. And so we'll kind of compare and contrast what we do now. So this is out of the Cleveland Clinic. What they did is they created a CRT response clinic. Kind of cool. And so what did they do? So they had different steps. And so they did laboratory tests. So you look for, electrolytes and anemia. They did a chest x-ray to look at the location of the lead. They did an ECG with and without pacing, and we'll talk about that. And then they did some kind of functional status and assessed how they're doing. And then based on that, they kind of looked at, well, what do we need to do for the patient? And so the next slide kind of looks at this. So what is the kind of the approach to the lack of response? And so what are the reasons? So again, I kind of say this is 2009. So it's changed a bit. Because number one here is what? Number one is AV optimization, right? So they thought at that time that 50% of all of the cases of non-response were because you were not AV optimized, right? Now, obviously, we probably don't believe that, and so it's a bit different, right? So we don't AV optimize everybody. However, second on this is arrhythmia. So atrial fibrillation, PVCs, et cetera. We do believe in that. That's still one of the major causes of lack of response. Now, the third one is a surprise, right? Anemia, right? It's way up there. 20, 30% of people were felt to have anemia as a cause of lack of response, right? Can we treat anemia? Maybe, right? So that would be pretty good. And then the fourth one listed here is suboptimal lead position. Now, again, in 2009, that probably was as big as 20, 25%. Hopefully now we're down in the 10% or something like that. The next one over is biventricular pacing, less than 90%. And then kind of related to the arrhythmia side, that probably is still pretty significant, is what most people would say. Suboptimal medical therapy hopefully is not as high as 20%, so hopefully we're doing better now in the modern era with other agents, et cetera. And then you go into the miscellaneous category, a variety of different things, one of which, as you see, is underlying narrow QRS. I think they're looking at 10%. That's really high, I think. So I don't think we have that many people who are BIV pacing who are truly narrow, but maybe. And there's things like RV dysfunction, which I actually probably would guess is much more than what they've indicated here. So there are other reasons people can actually have this lack of response, and that's some of the things we're going to talk about also. So when we look at this 10-step approach, what do we start with? So we generally start with what the percent BIV pacing is, because if you're not pacing at all, you're not going to get any benefit. So you have to kind of deal with this up front. So the first thing is, how do you look at that? What are your counters? How can you examine that? So clearly we want to get as close to 100% as possible. But what's the difference between 97, 98, 99, and 100? I think Dr. Russo mentioned some old latitude data that said, wow, the difference between 98 and 99 is real, right? You can actually improve mortality maybe. Hard to know. And how much you have to do to get that extra 1%, often is difficult to achieve. So a little difficult in my book to know whether really it's worth pushing so hard to go from 98 to 99 or 99 to 100. But nevertheless, you got the idea. You want to be at that upper level. The other thing we probably have to consider is the triggered responses are probably not as good as true BIV pacing. That the literature is pretty strong on. Some people say it's meaningless, that it's actually worthless to do. I hope it's a little meaningful. It's a little hard to know. But we shouldn't count those as equal to 100% BIV pacing, even if you trigger, all the rest of them. And we'll talk a bit about PVC counters as well, but we want to get some assessment, or PVC is important. So that's step one, assessment of the percentage of pacing. Step two is a little less applicable in the sense that we probably don't do this as uniformly as we could. And that requires us to look whether this is real capture or whether it's pseudofusion. So what do I mean by that? Well, the device says it's 100%. So as far as the device goes, everything is perfect. But suppose that 100% is just pseudofusion and not real capture, then you're not probably doing anything for the BIV pacing, right? It's not having a hemodynamic effect. So that's the idea. The issue is, how do you assess that? So you can look on an ECG, a Holter, et cetera, and see, does it appear to be true capture, or is it in fact is pseudofusion? There are ways now that devices do give you some index, or can do this, of when they see effective versus ineffective pacing based on pseudofusion versus real capture. And so they have these intracardiac electrograms that are recorded to get an idea of, yes, indeed, it is like complete capture. So they can do it with the templates, and they match the templates and see whether in fact you have effective CRT. And so that's basically what it does. It measures this percentage of effective versus ineffective, and that's one of the other things that are frequently available. Step three, you go back to step one and you say, well, you don't have 100%. What should we be doing? What are the causes of that? So there we're going to look at the arrhythmia count, right? So if they have a lot of AFib, we're going to look at the ventricular rate in atrial fibrillation, because that's what we're concerned about. We're going to look at the PVC count, see how many PVCs are. You're going to look at the rate histogram to make sure you're just not at the max track and above. And then if there are episodes where you can look at ventricular sensing episodes, that'll give you a lot of information of why sensing is occurring. So all in composite, that's what step three is, why in fact you don't have 100% BIV. So step four is, well, we've got to do something about it. So if they're atrial fibrillation, you're going to get more rate control or rhythm control. PVCs, you're going to try to suppress them, maybe even ablation, and those kind of things. There are algorithms that can intervene with atrial fibrillation and kind of force pacing faster and faster to be able to pace more. They're somewhat effective, but again, probably you really need better rate control in general. What about this kind of patient? So an older patient, advanced heart failure, been in persistent AFib, resistant to medical therapy, has been unsuccessful, and their BIV pacing is low because their average rate is still high in atrial fibrillation. What do you do about that person? So obviously I presented it so that you're not like so enthusiastic about doing an AFib ablation, probably, but you might even consider AV junction ablation. Okay. So what is the evidence for AV junction ablation? To the extent there are studies, it's very supportive of using AV junction ablation in the setting of uncontrolled rates, meaning improvement in outcomes overall, even all-cause mortality, ejection fraction. There seems to be a benefit. And so that's not as unexpected as you would think, right? Because we know CRT improves outcomes. And so these people don't get any, really minimal benefit because they don't have enough BIV pacing. So once you restore 100% BIV pacing, then they get the benefit. So it makes sense. So I think probably we under-treat. We don't do as much AV junction ablation as we probably should as a result. But, and so we include this in just to remember that it should be one of the options. So step 4 in this continuing on is increasing this percent BIV pacing, increase your max track if you're running into faster rates, and then you want to look at the different algorithms you have placed. So we talked about this before, the things that mainly PMT algorithms, which could cause things to fall into PVARP. You want to try to minimize that overall. This is just as a refresher. We can see here it's going from AS V pace to AR. So when does that occur? It's when your PV plus PVARP is longer than your atrial rate. Your atrial rate is faster than that interval. So that's when you'll lose pacing, and then you'll regain it when the opposite occurs. When your PR interval plus the PVARP, you exceed that interval, the intrinsic TARP, and then you'll get resumption of pacing. All right, and we talked about algorithms. Okay, so what about this situation? So non-ischemic cardiomyopathy, we mentioned this is one of the cases yesterday, has 100% BIV pacing. The lead's in a good place. And you say, well, how come the person's not a responder? So we do want to remember to do an ECG with and without pacing. That's generally not conventional practice, right? You might get an EKG, but it's with pacing. So it's a bigger deal to say, oh, you got to come back in the room again and do another ECG while I inhibit pacing. But that's probably what you should be doing in this kind of situation, just to make sure it's not that 5 or 10% where the QRS is probably pretty narrow. All right, so that's the underlying QRS duration. All right. What about the next issue of lead position? So what do we know about lead position, and is this still controversial? So generally speaking, what has held up the best is that non-apical is better than apical. That pretty much every study has confirmed over the time. After that, the literature is a bit more, discordant. So they don't agree always on where it is, but they agree non-apical is better than apical. So step 6, indeed, is to assess the lead position. You can try to do that with PA lateral x-rays. I think it's still relatively more difficult. It's easier to look at an LAO and RAO. So you can see here in RAO, you can kind of see where the lead is, and then in LAO, you really can tell is it basal lateral or more posterior lateral. So you can get a good idea of where the lead position is. So the next question is, what do you do about that? What are the options? Suppose you decide that, in fact, the LV lead isn't in an optimal position. What should you do then, right? You have what you think is a non-responder. Should you go and revise the system? So if you have available the venograms, then certainly look and see what the branches look like, because for some reason they didn't put it in a good place. But you don't know unless you have it in the op notes, go back and see why it was. Was it because of phrenic, dislodgement, et cetera? But particularly if that was a few years ago and they didn't have the current techniques and technology that we have, you'll have to decide, is it worth to go back in and revise this system, right? So you can see, with a quad lead system, modern techniques, you might be able to find a better position. So that's one of the questions. So there's, modest literature showing that even just having a quad lead compared to a bipolar lead can increase the success of the procedure. So you have a lot of, benefits. You can have many other targets, more likely to be stable, et cetera. All right. Any questions about that so far? Those type issues? Anything you want to talk about so far? So we'll continue. So related to this lead position, the question is there another way besides anatomically looking at it that, I recommend? So I personally use QLV, right? It's very simple, very straightforward, easy to do. Everybody can do it. And there's a reasonable amount of literature that's held up over time, in my opinion. So I use QLV. So how do you do that? What do you assess for the LV delay? So you can do QLV, which is the onset of the QRS complex to the sensed LV. That's QLV. Or you can use sensed RV to sensed LV. That's like the device may measure that for you because it can measure intrinsic RV sense and LV sense. So this shows, I showed this yesterday, it shows an example how to measure it. So you drop a line from the onset of the QRS to the intrinsic LV. It could be either short, or it can be long. So that's what you're looking for. And as you kind of see here that I showed you yesterday, that it continues on. It's a continuum. The longer, the better. So indeed, better than having a cutoff of QLV, it's really, are you at the end of the activation? Are you end of the QRS? That's really probably the more important question to ask. And so it's important to kind of push yourself. Like sometimes I think, oh, I got a great QLV, it's great. But in actuality, I probably could have found a place that was later. It was closer to the end of the QRS. So because it appears that you continue to get benefit. All right. Before we go to AV optimization, I just want to stop. Are there any other questions so far before we go on to talk about AV optimization? Anything you want to talk about? Yeah, thank you.
So you get into CS, you do a venogram.
Yes.
And you see, okay, is there one or greater possible target?
Yes.
And then you go into all what you would consider possible targets every time.
So the question is, okay, you do the venogram, you get the nice picture, you see what you're going to do, and do I go to every branch possible? So there are some people who advocate that. I have to admit I don't do that. I go to what I think is the best place, and then I'll measure QLV there. So if it looks adequate and that's where I want to go, it looks really good, we're at the end of the QRS, I'll take it. It's a cross-check because I already placed my lead there, and I'm just, before I secure it down and slit, I'll go ahead and make my QLV measurement. But, probably should go and measure all the branches I can and do that. But generally speaking, I think we have a decent idea that probably that's going to be the area. And then I'll compare the different poles. That I will do. In a quad lead, I will compare the QLV at the different poles if we can capture without, fretting. So, yeah, great question. Other questions at this point? We'll come back to them. All right, so let's go through AV optimization. Again, not something I do routinely, but I think you should all know, how to do this, right? Okay, so what are your different options and what do you have available? So you have empiric settings, you have device-based manufacturers, and you have imaging like echocardiography. So how do you set this? What would you go about doing it? So echo-guided, a fixed, we don't really use DPDT. So indeed, in average practice, we either use a manufacturer or you pick a fixed interval, probably on the shorter side, 10 to 100 to 120 milliseconds, et cetera, depending on the definition you're using on the LV-RV offset. As you all know, aortic VTI is generally what's used. It's, maybe a little noisy as a signal because it's maybe not super reproducible, but generally that's what we use to assess cardiac output. Kind of showed this yesterday. You have this idea that the E and A waves will be separated, and that's what you'll be looking for. When you look at first degree AV block, left bundle branch block, what is happening, right? So as I mentioned before, what you're looking at is the E wave, as you know, is actually from the previous beat, whereas the A wave is from the subsequent beat. So the delay in depolarization translates to delay in repolarization and filling. Therefore, it pushes the green triangle, the E, to the right side. So they tend to merge. And then when we get bi-V pacing, optimally they're separated again. Now, what we don't want to do, as we mentioned, is to have a too long a period. You'll start to get presystolic mitral regurgitation because you have too long a time. You have atrial contraction and you're waiting around then to close the AV valves with after systole. So you don't want that. Neither do you want to do atrial contraction, and then before you can allow emptying to occur, you start to contract in the ventricle. So truncation of the A wave is also not optimal. So somewhere in the middle, you separate the two. So contraction, the two are separated, but not too early, so you get contraction, not too late, too long, so you can get regurgitation. All right. Okay. So how do we do it? How do I do it? So I start short. The AV lay short, and then progressively lengthen it to see where your optimal positioning of the timing of the E and A waves. So it's visual. All right. And then, an alternative is to measure aortic VTI. Many people do that also. So you have another way to go as well. And you see here an example where we've gone from left bundle to CRT, and you can see that the mitral regurgitation, bless you, has gone away. So you can see that as when you are measuring as well. What about formulas for AV intervals? So there are a number of formulas. So you can employ those, or you can employ manufacturers' algorithms. As I mentioned, the manufacturer's algorithms are really varied. So this is the smart delay that Boston uses. So it uses intrinsic AV intervals. It uses the V to V timing difference and the LV lead, and that all gets incorporated into this algorithm. QuickOpt does something different. It uses like the P wave duration, for example, and incorporate these in the variety of tests that are used to optimize the settings. How do most of these algorithms come out? They come out generally okay, but generally the literature hasn't shown that these are home runs by and large. And you'll kind of see the literature. This is a study that was done for smart AV delay, but it shows that it's probably equivalent to echo, maybe better than fixed, so a little hard to know, but again, a reasonable rationale to try to use it. This is a study that goes on to look at when QLV is the longest, that you may have the biggest impact by using these algorithms. So what it tells me is, yes, there's more to perfect, and you should probably kind of push, particularly when you have a lot of delay. All right, so fixed AV delay might be functionally something like 100 to 120, again, to preempt your activation if your PR is normal at 160. All right. So this is another topic. So what about LV pacing only? You may be familiar with the early literature of LV pacing. And generally, the early literature of LV pacing was a wash, meaning it probably was no better than bi-V pacing and maybe worse. So that's why we kind of abandoned LV only, and that's why we still use bi-V pacing today. So what is this little figure trying to show? So this is an acute hemodynamic study. It's done about 10 years ago. And so what is it looking at? Well, on the left-hand side, you see, in fact, the intrinsic DPDT, right? It's about 1,000. When you go to the right-hand side, you see bi-V. And so what can you tell? Well, there's a sweet spot, right? It's somewhere around 100 to 120 milliseconds, what we mentioned before. It's kind of the sweet spot of bi-V pacing. And it's better, it's up to, whatever you say, 1,000, 1,100 or so. So it's better than intrinsic, right? So that's what we'd expect to see. What happens for LV pacing? So what are we doing here? We're measuring the relationship between the RV sense and the LV pace. If you look at where it says in the middle, ARV sense, it's timed equal to that. That's like triggered pacing, right? And if you go over to the left, it's no better than intrinsic, right? So this is the idea why triggered pacing is probably not so helpful, right? Oh, I see an RV, let me pace the LV. by and large, it's way too late, right? Because the activation is so delayed on the left side that that's not preempting enough. But if you see something that if you walk by 20 milliseconds earlier, 20, 40, 60 milliseconds, you see how DPT rises. It seems like it keeps going, right? So what you're doing is you're preempting activation by pacing the LV and giving it a pretty substantial head start before RV pacing. Before RV sensing. So you're doing a couple things. Not only you're preempting, but you're allowing the RV to be activated intrinsically rather than through pacing, right? So this is the idea that was incorporated into adaptive CRT, which you see here. So how do you do that? Well, we know the PR varies over time with exertion and hemodynamics, et cetera, autonomics. So you have to have some way to keep track of where the RV sense is going to happen because you're preempting it. You're predicting what's going to happen after you. So you have to have some idea of how dynamically the RV senses. So that's what the algorithm does. It keeps looking and looking. It'll stop by V pacing, see what RV sensing is, and then incorporate that distance from the atrial event to the RV sense as to where to position the LV pace. And by preempting it, that's how the algorithm kind of works. The initial studies kind of showed it was a wash compared to echo, again, very similar to SMART AV. And then when they looked at the primary endpoint, all the people together, it was pretty much a wash, as you see. But when they did subgroup analysis, you see something kind of amazing. And you see that the percentage of LV pacing made a huge difference. So if you're doing adaptive LV pacing greater than 50%, there was a huge difference, like a major observation between that and the other group. And they're splayed out. And so there are ongoing studies to look at, again, the subgroup of people who are going to be getting more adaptive LV pacing to see if they can reproduce this. So that's kind of what, is still going on. We talked a bit about RV, LV offset. There are formulas that can be used, and the other way we do it is using aortic VTI. So that's step 8. Step 9 is also very important, and that is to look at cardiovascular, or at least the other non-cardiac causes, et cetera. So there are some cardiac causes that you should incorporate. Those are things like RV failure, valvular heart disease, ischemia, those being some of the key things. And then for non-cardiac anemias, we've seen pulmonary causes, miscellaneous other abnormalities should be considered. And our last step is step 10, and that is, are your expectations appropriate? And I put a lot of weight on this. So what do I mean by that? I say that people who have non-ischemic cardiomyopathy, have left bundle branch block, and really wide caresses, I expect them to be significant responders. Now, we all know that non-ischemic cardiomyopathy is really a diffuse, there's so many conditions, right? And some people have very extensive myopathy, right? So their idea of improving substantially is going to be, maybe only modest. There are other people who their major problem is electrical. They have a modest amount of, myocardial disease, but it's largely electrical. Those people should be super responders, right? So we try to get some idea, in doing that. People have done MRIs, looked at amount of scar, all these different things, and have looked at this, dobutamine, et cetera. But you get the idea. You should have some idea as you approach your patient of what your expectations are. And in doing so, I try to determine how aggressive I'm going to be. So I try to be super aggressive in this patient population, in terms of getting a response. And so that's the idea. As you can see here, study after study shows, yes, there's benefit in ischemics, but the benefit is much greater, quantitatively in non-ischemics. All right. To summarize, the 10 steps. So step 1, confirm that bi-V pacing 100%. Don't really consider the triggered so much. Step 2, look at this issue of pseudofusion versus capture. There are algorithms, you can use ECGs. Step 3, figure out why there's not 100% bi-V pacing. Atrial arrhythmias, ventricular arrhythmias, max track issues, et cetera, algorithms. Step 4, what are you going to do about it? We're going to get better rate control. We're going to get rid of the PVCs. We're going to get rhythm control, get rid of the algorithms, increase max track. Step 5, we're going to look at the underlying duration, do an ECG with and without pacing. Step 6, what is the lead position? Is it optimal? If is it not, can I conceive that I could go back in and modify, revise the system for a better location using modern techniques and technology? Step 7, is there a way we can assess delay dynamically? Things like QLV, other kinds of measurements. Step 8, if they're non-responders, should you go ahead and do echo optimization, separating the ENA waves, looking at the maximum aortic VTI? Step 9, look for other causes, anemia particularly being right ventricular failure, valvular disease, anemia, et cetera, and ischemia. And then step 10, are your expectations appropriate? Is this somebody who should be a super responder? How far am I going to go? Am I going to revise the system, et cetera? So hopefully that was helpful as a overview of 10 steps that you can use that really allow you to examine what you're going to do for the non-responder, but maybe for all your patients who get BIV. So happy to take any questions. Thanks. So other questions? Yeah, thank you.
I had a gentleman who was limited anatomy, phrenic in some areas, high thresholds in others. And the one area that we found an acceptable threshold that was not phrenic seemed to make his PVCs worse. Do you have experience where pacing is causing more PVCs? And so ultimately we turned his lead off.
Yeah,
kind
great.
of, as opposed to ablated him because it almost went away when we stopped.
Yeah, absolutely. So the phenomena of proarrhythmia, I believe, is real. So it can occur, I believe it does occur, and you're kind of messed up, basically. I don't know what to do. You're going to have to, generally, I turn it off. So, if you figured it out during the implant, I guess maybe that would be a really good time to figure it out. Maybe there are places that you could have paced that won't do it. Presumably there are. Presumably it's not the whole heart, and there are other places you could have gone. So, yeah, stay alert while you're doing the implant, and maybe you could get a sense then. We usually don't. It's usually when they go back to the recovery and you get called, the person's having lots of VT, And so the first thing you do is determine, well, is it a lead dislodgement causing it? No, it's the CRT, because every time I turn it off, it goes away, and I turn it back on, it comes in. So I'm pretty convinced. And so it's really hard. I can't say I've ever gone back and moved the lead just to see, but it's another idea. Certainly with a quad lead, I would try all the different, poles and different configurations before I, totally said it's off and I'm not going to use CRT. But it'd be nice to have that idea, because what are you going to do after, right? And if you really think this person's a super responder, what would you do, right? It'd be hard to know what your next strategy is. Would I send him to a surgeon? I wouldn't know that's going to work, because they could find a place that's bad too. So hard to know what to do. So that's a really difficult scenario, in my opinion. But one you should recognize early, because it's real, in my opinion. Good. Other questions that come up? Some of the other things that we still, I think, suffer from is phrenic nerve. That's still an issue. I thought we were beyond that, frankly, but I thought quad leads were going to solve that problem, but they haven't entirely, right? So it's still an issue, and we try to do the best we can. I try never to accept a position that in the lab we get any phrenic. I usually find that I'm kicking myself when I say, oh, well, but there's a huge threshold difference. The phrenic capture is, is really high and the thresholds are really low. It'll be fine. No, usually not. It gets worse. So I try not to accept that. There are obviously people who have no phrenic in the procedure and then they come back and get phrenic, probably because of just their lead sitting differently, or it pulls back a little bit, or that kind of thing. Obviously, we have better, more stable leads now, so we have a little less of that, but it still happens. So what do you do, right? I saw a patient last week. He basically has phrenic nerve stimulation. And, we had the talk. We said, well, do you want to revise this? And he said, Doc, you saved my life. My EF was 17%. It's, 55 now. He can do everything he wants, et cetera. And he has a reasonable amount of phrenic nerve. His wife says, when he's asleep, it looks like he has a baby kicking him. It's like this. So, and she says, I have to live with this. And he says, yeah, I do too, but I don't want you to mess with my lead. I don't know, maybe something will happen. It won't be as good, And so he says, no, I don't want you to revise the system. I'm staying with it. So, it's a little hit with quality of life, clearly. But, in the bigger picture, that's the trade-off that he made, right? So I was happy we could try to revise it or whatever, have a surgeon come in or whatever. But, he said, no way, I'm staying with this. So everybody has a different idea about how they're going to solve this. Again, I wish we could get rid of phrenic entirely, but, we still have some. Thanks.
What are your thoughts on the active fixation CS leads, and are you reaching for them more often?
Yeah. So it's a great question. The big picture is that we're fortunate to have such variability and a wide range of technology. And the key thing I use is you want to individualize what you're dealing with in terms of anatomy, where your targets are, what your sweet spot is, where you're trying to go after. So, definitely my rep comes in and says, oh, you're using active fixation, aren't you, today? And I'll say, well, let's figure out what our target is. Let's figure out which branch we're going after and make a decision. So, yes, probably use it as a general go-to lead, but I'll pick out a straight tine lead if my target is a little squiggly thing way out laterally that I think is going to be the best thing. It's probably going to be fine, right? So on the other hand, I don't want to take a stability lead and get it shoved in. You don't want to get it wedged, right? That would be bad, right? So you won't be able to really get the screw to screw in. So so I try to be individual as to what we do. But certainly, stability allows you to, active fixation allows you to pick sites you wouldn't have picked before, and which gives you a whole lot of freedom of where you're going to be able to go, right? So you can avoid phrenic, you're going to have dislodgements, all those kind of things. So it's another major advance, in my opinion, in terms of what you're looking at. Quad leads alone, before we couldn't have taken that, right? Because we would have shoved the lead in far to get, stability, but we got phrenic there, so we had to pull it back, and then the lead dislodged. Now you can at least shove it in and pick another pole, so you have a lot more flexibility there as well. So, I think you want to individualize, look at what your options are, and then make the call which lead is the best. Yeah, thanks.
Got an online question. How do you approach patients that have lots of PMT, for which you extend their P-bar, but it compromises optimal amount of IV pacing?
Yeah, great question. PMT is intolerable. I mean, you just can't have people have this. So you're going to have to work around it, basically. You're going to have to accept these, the algorithms that exist, you're going to have to utilize them. So hopefully that's not a big factor in reducing the amount of pacing. So I think that's the compromise you're going to have to go on. So, good. Yeah, good question.
Do you ever bail out to left bundle area and use left bundle area before sending to surgery?
Yeah, good question. So the question is, what about bail to left bundle, versus not? Certainly within our colleague group, big variation in practice, as there is nationally. Me personally, just me, it's going to be based on that step 10. What's my expectation? If I think this is somebody who, is this left bundle branch block, non-ischemic cardiomyopathy, and, probably may not have so much myopathy, I don't know. I'm probably going to go surgical and have them do an LV lead. That's just my choice. That's where we are today, in my opinion. In the future, we may take a different call, and it may be left bundle pacing, But I think we know so much about CRT that we know that kind of person has a really good chance of being a super responder. And you know, I mean, that's life and death. You know, that's like going to determine, you know, life expectancy and every quality of life. So I'm pretty sure the surgeon can do it pretty safely, and we're going to get a good response. So that's what I'll do generally. Other people I know would go to left bundle pacing. So the other people who aren't the super responders, that's a little mushier, right? You know, okay, I wasn't, you know, the curious duration was borderline to begin with. Oh, okay, maybe we won't, you know, do that. So there's definitely a spectrum. So it's a well-taken, very good question.
And what about at initial implant? Because, I mean, you could potentially be done without another procedure.
Oh, that's what I'm talking about. I'm talking about the initial implant. I'm making that call on the scene which way I'm going. Oh, absolutely. But I'll leave the room with that decision made. So either I'm going to put a device in that's, you know, going to accept a bipolar lead that's going to be epicardial, and I'll pick that device, versus I'm going to either come back again because I think, oh, I just had a, you know, I didn't say bad day, but I could come up with other tools to get into a better branch, or I'm going to bail and go, physiological pacing. So I'm, you know, yeah, you have to make the call then. So. Good. Other questions? Yeah, did you have one, Rich?
Marna needs you to look at the Jeopardy questions.
Oh, okay. All right. Anything else? Anybody else? Okay. Thank you so much. Hopefully that was helpful. Thank you.
Okay. You know where the clicker is? Does anybody know where the clicker is? I feel like I want control. All right, here it is. Okay, shall we get started? Everybody ready? So I think this is the room that has all the pediatricians, right? So pediatrician, there's a couple more. So you guys are going to keep me honest. Let's go to the first slide, please. Thanks. So I'm going to tell you my origin story. You know, how did I get into sort of the congenital thing, right? And so my dad's a pediatrician. And so I've always wanted to be a pediatrician. I really, really wanted to be a pediatrician. And I went to medical school, and during my pediatrics rotation, the kids hated me. Like, I would walk into the room and they would cry. They would just, and it didn't do that to the other medical students. And so it made me feel very, very inadequate and awkward. It kind of really hurt me. And so, in fact, and that's why I didn't be, and maybe my personality is better suited for cardiology, but when my kids were born, I was kind of worried that if they were going to like me. I mean, fortunately they do, but you get the picture. So when I started on as faculty, we were working very closely with the pediatricians, and they sort of said, hey, would you be interested in doing a lot of our adult congenital stuff? And it was an area that I didn't know a lot about. And so I said, yeah, I'd be happy to do that. Let me do that. And so I became actually the only adult cardiologist at the time that actually had privileges at the pediatric hospital. And so I would do cases at the pediatric hospital, and I would assist them, and learned a ton of stuff. So it's a very, very important area. The thing I would emphasize to you, though, is that you may not end up with an origin story like mine, but you will see these patients. These are patients you are going to see, okay? And it may be something that you're comfortable taking care of, but you ought to know enough about when to refer some of them and what to worry about in these types of patients. So let's go to the first slide. Can I use the clicker? Is that okay? Okay. Got it. Okay. All right, here we go. So we're going to talk primarily about congenital type stuff. Oops. Yeah, so this is kind of a listing of all of the different things you'll see. And I don't really think you need to memorize any of this, but just to get the sense that there's a lot. There's a lot of problems that you're going to see in these types of, and there's some very specific lesions that I'm going to spend a lot more time on that you will definitely see in general. The big problem with these patients is that there's a high percentage of bradycardia pacing in these patients. A lot of them have sinus node dysfunction. Some of them have AV node dysfunction. They'll have right bundle branch block. The His-Purkinje system is not always optimal. And so these are patients where you're going to need devices. And of course, is a device talk. A good example is a transposition, okay? So does anybody know, with a transposition mustard, how that works? Anybody want to share? What's going on with the transposition mustard? Yeah, so this is a situation where there's a switch, right? And the way they fix the switch is they switch the atria, essentially switch the atria. So they're kind of doing an atrial switch procedure. And the problem when they mess with the atria is that ultimately these patients end up with sinus node dysfunction. And the other thing they end up with is atrial flutter. So those are things you need to anticipate in this population. Now, do we see these patients at all or no? Yeah, we still do. Are we going to continue to see them? Probably not, right? So now what's going on is they'll typically do an arterial switch. And if you do an arterial switch, these patients have normal anatomy, you don't have to worry about them. But when you see a patient with an atrial switch, a mustard or a Senning, you really need to think about sinus node dysfunction. Let me ask you a question. When you have a patient with a mustard or a Senning, and you want to do a pacemaker, where are you screwing in the atrial lead? Which part of the left atrium? The appendage. And what's right next to the appendage there? Phrenic nerve, exactly. So that's one of the things you have to consider. I can tell you, I remember one case where I was trying to put a lead in the left atrial appendage in a mustard, And I had to reposition the thing like 15 times because everywhere we put it in, and it's not like you can really manipulate that lead a lot. I mean, you're going through a baffle and it's not that easy to do. Now, the other thing you need to be concerned about is vascular access. These are kids who often have had multiple procedures, lines, IVs, devices, things like that. And so vascular access ends up being important. They may have stenoses, they may have occlusions, they may have obstructions. And so getting to where you want to go may not always be as easy as you think. And there are other challenges: absence of the atrial appendage, presence of a baffle, shunting from one side to the other side. So it turns out that these patients actually have a high risk of systemic emboli, primarily because of shunting. So oftentimes, you can put a lead in, but you really need to consider, you need to put them on anticoagulant therapy as well. Some of the specific concerns, this one ends up being a board question. Left phrenic nerve in the left atrium, left atrial appendage. The other one that's an interesting one is the congenitally corrected population, right? So these are patients that don't show up as pediatric patients often. They often present as adults or as young adults with systemic ventricle failure, right? And their systemic ventricle is actually the right ventricle, not the left ventricle. The non-systemic ventricle is the left ventricle. So if you want to put a lead into the left ventricle, which is the non-systemic ventricle, what kind of lead do you want to put in? Well, it's got to be a screw-in lead because there's no trabeculae. And oftentimes we put in screw-in leads anyways, but just sort of thinking about it, it's a different ventricle. You're putting it in a different ventricle. Okay, and then access to the ventricle for pacing is another issue. What if they have a Glenn? What if they have a Fontan? How do you get in? So here's a patient. What's the congenital abnormality here? This one's an easy one. This is warm-up. Yeah, it's just a persistent left, right? Easy peasy. So you guys all know how to do this. You just loop it in, no problem at all, right? Use a long lead. We talked about that yesterday. Good. What about this? What's the anomaly here? Yeah, so this is a TGA with an atrial switch, mustard or Senning, and the lead is being screwed into the left atrial appendage. And this is actually the patient I was telling you about where we had to reposition that lead a bunch of times to get to the right spot. So not always an easy situation. What about this? This is actually a patient of mine who had Eisenmenger syndrome. She was born in Russia. Weird story. So she actually wanted to have a baby, and she was blue. I mean, she was walking around cyanotic, never got corrected. Ultimately found a surgeon in France. So she flew to France who would do egg harvesting, had a baby through a surrogate. I mean, the whole story is very weird. But ultimately she comes back and develops complete heart block. Where are you going to put the lead? Any takers? Yeah, you're really stuck. You got to go epicardial in somebody like this. Now, if you were to put the lead in endocardially, right, it is in one big systemic ventricle. And the problem there is you're going to end up with thrombi on the lead and strokes and issues like that. So you need to think about that. And that's an Eisenmenger's type case. Similar in a Fontan, right? In a Fontan, you may not be able to get into the ventricle. You may have to go through the CS, or you may have to get into the systemic ventricle, which is not advisable. Okay, what's this? This is an Ebstein's. So tell me, what is an Ebstein's exactly? Any takers? Yeah, and what happens to the right ventricle in Ebstein's over time? Yeah, it goes in heart failure. It dilates and it fails ultimately, right? So the right ventricle tends to fail in these patients. And so what kind of procedure do they do to help with that, to help decompress the right ventricle? It's called a Glenn anastomosis. Does anybody know what a Glenn is? It's a conduit. From what to what? Yeah, well, from the SVC to the PA, right? So what they do is they connect the superior vena cava to the pulmonary artery, and then the right atrium essentially gets closed on the top. So what happens is if I'm trying to put a lead in from the shoulder going down the superior vena cava, am I going to get into the right atrium? No, pretty much I'm not. So how am I going to put a lead in? You could go hepatic, you could go, groin, you could put a groin system in, or you could go epicardial. I mean, all of those are
are reasonable options. This lady actually ended up having the hardest case of PMT I've ever seen. In fact, I didn't know what she had, and I took her to the EP lab only to discover that she ended up having PMT. It made me look like a fool because I'm like, I diagnosed PMT in the EP lab. But it was just because everything is slow and, conduction is different, and I saw it on a monitor and you couldn't reproduce it, and so ultimately, but this is what you're ending up with, is stuff like this.
Was it sinus node dysfunction?
She had some level of AV block. She had a wide QRS, and she did have sinus node dysfunction, yes. This was pre-micra. Micra is an option. I don't know how easy it is to put a micra in a Epstein's. I've never done it. I'm not sure I'd be enthusiastic about it. I mean, maybe I just have to try and see, but I don't. There's not that many Epstein's out there that have micras, as far as I'm aware. Yeah, it's hard to get in. That's part of the problem. This is something I took off of the internet, and so this is somebody who put a lead in through a gland anastomosis. And so you can kind of see how that lead goes from the SVC to the PA and down to the ventricle. And so I'm not sure I like this, because one of the problems with this is in these types of patients, you really want to make sure their PA pressures remain low, right? They don't do very well with high PA pressures, and putting leads in here, I think, is problematic. So yeah, it looks like a dual quote, yeah. Okay, so here's another issue that we have to deal with. Given the age of the patients, 77% of the patients receiving devices are under age 18. The patients that ultimately end up adult congenital. This is problematic because now you've got decades and decades of life that you need to worry about. And about half the leads implanted in that age group are epicardial leads, and we know that epicardial leads don't work very well, and I'll show you some data. Lead longevity in general in these patients is poor. Highlight this, look at that, 36% lead fracture over 6 years. There is no population that we deal with that has problems like this, period. Nobody else has problems like this, right? This doesn't exist. And this is data from Children's Hospital of Philadelphia, 663 patients. These are all epicardial. 27% failure at 5 years, 55% failure at 10 years. What does that mean with epicardial leads? That means they're going to need a reoperation every 5 to 10 years. So what that's led to is a lot of people putting in redundant leads. This is a study from Stanford that looks at using redundant leads. And if you can put in endocardial leads, sometimes what this group actually did was they put endocardial leads and then essentially tied them to the same can. So they put in a BIV can, 2 RV leads, or something like that. And so there are ways you can do this, but these leads, I mean, the reason they even came up with this study is that these leads fail, okay, at a very high rate. Here's a patient of mine. This is a lady who had tetralogy flow. She was a musician from Hungary, very sweet lady, 55 years old, was the first patient in Hungary ever operated on with tetralogy, did fairly well, ends up with a pacemaker, complete AV block, and now has a fractured lead, also has SVC syndrome, and you can actually see there's a lead fragment there. What's hard to see is that tip of the pacing, of the temporary pacing wire that somebody put in. Wasn't me that put it in. But look how far out that is. It's like, look at how ginormous, and that's a medical term, ginormous, her right ventricle is. It's massive. And so what do you do with this lady now? What are your options? What's that? Yeah, so an extraction is very reasonable with somebody like this. So this is what we did. We extracted her, we stented her SVC, ballooned everything, and then we reimplanted her on the opposite side. So that worked really well for her. And we'll come back to this lady in a little bit. Actually, what about sudden cardiac death? Turns out sudden cardiac death is the most common mode of death in these patients. And the problem is that our data that exists in these patients is not randomized. It's all retrospective data. Nobody is going to do a randomized study in this population ever. It's just not going to happen, right? And there are issues with these patients. DFTs are an issue. Now, I can tell you, I'll share with you another case with DFT issues. Lead-related problems, and then you're often dealing with epicardial systems. And again, I'll show you some cases. This is an old study, kind of in the early days before ICDs. I just want you to focus on the red red arrow there, that's the tetralogy population there, okay? And the tetralogy population is very important because that continues to happen, and you will see tetralogy patients, period. You're gonna see them, okay? And so in this study, it's a small number, but about a quarter of tetralogy patients in this study died suddenly. 1/4 died suddenly. That's crazy high, right? It turns out because tetralogy is so common, that we do have a lot of data on tetralogy. And this is sort of a summary of all of the different things that have been looked at in tetralogy. And some of these make obvious sense, right? So older age, severe RV enlargement, some of them make sense. I've highlighted the things that have ended up being recurrent themes in multivariable analysis. And so elevated LV and diastolic pressure, a wide QRS, and inducibility in EP study. And particularly inducibility in EP study has very strong data that suggests that those are patients who are at increased risk for sudden death. This is data from Taiwan, 4,700 some patients, and what they found was 18% VT rate in tetralogy. 18% VT rate, very high. And the older patients tended to have more VT than the younger patients. It happens as you get older. Now, one thing that's interesting is there was a change in how tetralogy surgery is performed. Does anybody know what the change was? Valve-sparing repair. And then what's the approach? The approach used to be make a big incision in the right ventricle. Now they can do a lot of this through the right atrium. And so whether it's a ventriculotomy or an atriotomy matters, it turns out. And the problem, though, is when you see these patients in the office and they come to you and they had tetralogy and they've been repaired, you say, where'd you get your repair? How old were you? Oh, I don't remember. I was 2. Got my repair at UCLA. Try to get the records. Good luck, right? That's the problem. You really don't know. And so you don't know, did they have a ventriculotomy? Did they have an atriotomy? What happened? But now more and more the repairs have changed such that the risk of arrhythmias are probably going to decrease a little bit. But that said, this is probably one of the things that changed this field the most. Is this study from Paul Carey when he was at Boston Children's. And so what Paul did is he took patients with tetralogy and he did VSTEM. He did EP studies on them. And what he found was that if they were inducible, either for VF or for VT, their overall risk of sudden death in the future became much higher. And so based on this, actually, our practice changed where that now we offer these patients, in particular if they have a wide QRS, offer them an EP study. That's become standard, okay? This is an interesting study. This was published recently, 700 patients with adult congenital. About 18% of them were TET patients. And they assigned risk points, and they sort of looked at different things. They looked at coronary disease, heart association class, SVT, low EF, all these things. They gave you points, right? And so the more points you had, the higher risk you were. This is sort of the matrix that they came up with. And so you can see that, for example, if you have Eisenmenger's syndrome and you have 3 or 4 points, Eisenmenger's syndrome, your annual risk of sudden death is greater than 25%. These are astronomically high. Now, you're not going to probably see a huge number of Eisenmengers, but you will see tetralogy, and you will see Epstein's, and you will see a few TGA mustards, okay? And you will see congenitally corrected. These are some of the older, some of the guidelines, and so these are kind of no-brainers, honestly. If you've had a prior cardiac arrest, you need a defibrillator, no-brainer. If you have spontaneous sustained VT that's non-reversible, you need a defibrillator, also no-brainer. If your EF is low, and if your systemic EF is low, which you will see in a congenital corrected, honestly, because that systemic ventricle fails often, you need a defibrillator. And if you have inducible VT, this is sort of the Paul Carey thing, inducible VT, then you need a defibrillator, okay? So back to our patient, 56-year-old with TET, repaired. On her pacemaker now, we notice that she's been having episodes of VT. What should I do next? What's that? Upgrade. Probably needs, I mean, she's got complete heart block, we know that. So her QRS width is, not really measurable, probably high. So we did an EP study on her. In the EP study showed VF. We were able to induce VF. So now you all agree she needs an upgrade, right? It was a little more complicated than that in these patients. So what ended up happening with her is that it turns out she had bad pulmonic insufficiency, bad tricuspid regurgitation. So, this is not the kind of thing where it's like, oh, Amin's going to do upgrade. No, this is the kind of thing where Amin calls the surgeon and says, hey, would you just look at this lady, get the adult congenital people to take a look and just see, do they need anything else before we do the upgrade? And so it turns out that yes, we needed to have her go to surgery and get things fixed. And so in fact, she actually had pulmonic valve surgery, RV outflow tract reconstruction. The surgeon decided to put some cryo lesions for good measure in the outflow tract. I don't know. And then they put in this system here. So this is an interesting system, right? So they took an ICD lead, they tucked it behind, the tip of the lead is tucked behind the pulmonary veins, and then this coil here, that other coil there is kind of a non-functional coil, put in some epicardial pace sense leads for a BiV system, and then the can is up front. It turns out that this particular LV lead is right where the phrenic nerve is, unfortunately, so that became unusable. But aside from that, this system actually worked really well. What about this? Yeah, so this, I think, I can't remember if this was a Fontan or a Glenn. I think it was a Fontan maybe or something like that, but I think there was a young guy with a Fontan. And basically the system here is a subcutaneous lead tunneled behind the chest, connected to epicardial pace sense, and then an anterior can. And it worked really, really well. And so this was actually a pretty good setup. What about this one? This is a patient with a Glenn. And so this patient had VT, complete failure of the RV. So similar kind of story, right? They tuck a lead in the pericardial sac. You just got to make sure it's tethered down. But once it is, you're fine. And that actually works really well. That's the lateral. And kind of see how that system would work in bipolar leads. Okay, what about this one? This guy had tetralogy of Fallot. Yeah, so this guy had tetralogy of Fallot, sustained VT. I call him Pepsi Man because he was in VT, and when he was in VT, he kept asking for Pepsi. It was weird, and I don't know why the preference of Pepsi versus Coca-Cola, but that was his preference. And his blood pressure was low, but he just kept saying, I want Pepsi, I want Pepsi. And then we'd put him in a sinus, and he'd forget about the Pepsi. So he had a VT ablation, needed an upgrade, so he gets upgraded, right? So what happened in him was we put an ICD lead in, and we couldn't defibrillate him. So then we ended up putting an azygous coil, couldn't defibrillate him. So then we ended up putting a coil in the coronary sinus and couldn't defibrillate him. We could not defibrillate this guy at all. So this is what he ends up getting. You see these squares here? That square there and that square there? Those are epicardial patches. And so that's the old way of doing things. You got to order these and ask for them. But basically, the surgeon will basically put these patches and sew them on the heart and then connect those to the defibrillator. And that actually works really well. Yeah. Simultaneous arrays? Subcutaneous arrays. Well, some patients it does. I mean, in some patients it does. We tried just about everything in this guy and nothing worked. And so it ended up that patches were the only thing that really worked.
How's that patch connected on the bottom? Is it by a lead?
Yeah. There's a lead. Yeah, exactly. There's a wire that connects it up. Yeah. I showed you something like this before, TGA with an atrial switch. Sometimes you get some of these patients that are just extracardia, they're a pain in the neck because you're kind of upside down, backwards kind of thinking, but they're doable. What about this one? How much time do we have, Rich? Are we good? 15 minutes. Okay. This one's a weird one. So we had a surgeon that was fond of putting leads in through an atriotomy. And so what happens here is the surgeon basically creates a small hole in the right atrium, puts the lead in. It's a standard pacing lead, screws it into the heart, and then closes the atriotomy. And so these two pace sense leads that are in the heart are both put in through an atriotomy. They're not put in through the femoral system. They're not put in through the liver. They're put in through a direct atriotomy. And the reason that becomes important is because you look at the system, you're like, oh, it's a, Medtronic standard lead. I'll just pull it out. You're not pulling this one out, right? This is not a good one to pull out. So you need to know what the system is in these patients. And sometimes surgeons get very inventive and because these patients are all going to have problems, right? Because they're going to have lead failure and other issues. So you need to kind of understand what you're dealing with. I don't remember. This guy actually had a fairly complex congenital condition. I think he was a single ventricle subtype, and so it was something like that. I think it was something like that. Okay, this is just sort of a collection of studies looking at ICDs in adults with congenital heart disease. And one of the things I'd point out to you is one, a lot of these studies are pediatrics. Only a few of these studies actually contain adults. And then the ones that do, the number of adults are very low. And then the other thing I would point out to you is that the percentage of actually appropriate shock in these patients is actually quite high. And so these are patients that, for whatever reason, people become pretty good at selecting patients that do end up needing reasonable therapy. Now, the other issue with these patients is that they do have a high risk of complications. And so this is astronomically high when you compare it to the standard ICD population. Like, you've done a ton of ICDs now as an EP fellow. You know how to put in an ICD. Have you ever seen this? PEA 4 out of 400. I mean, that's insanely high. High DFTs, 9 out of 400, right? So these are numbers that are kind of on the high side, which basically means when you do see these patients, you need to consent them that they may have a higher risk of complications. You need to be ready for those complications. And guess what, you're doing this case at 9 p.m., it may not be the best case. It may be a case where you want to have some backup around, and if you're in a center where you're like, this isn't for me, maybe send it to somebody that can. And that's not always possible. I mean, I go and I fly to Amarillo, Texas, and there are patients that legitimately cannot travel. I would love to send them to a bigger center, but I got to do the case there. And so, those are some of the issues that you can deal with. Okay, but just to get an idea of the rates of complications, these patients are astronomical. This is another study. This looked at 100,000 patients, took a look at patients with complex versus not complex congenital heart disease, and those with complex congenital heart disease had a substantially higher, at least twofold higher risk of problems, primarily mechanical problems with the leads, lead dislodgement, et cetera, things like that. Okay, what about sub-Q devices, right? So maybe you should just put in a sub-Q ICD. This is a clever study. Actually, I think it was done by a medical student or by an undergrad. It was a very clever study. They basically took EKGs from a bunch of adult congenitals, and they took the Boston Scientific algorithm, and they tried to see whether these people would be candidates or not for a subcutaneous ICD, just based on the algorithm that they have, the shape thing for the T wave, for T-wave oversensing. And you can kind of see it's kind of not awesome, right? So if you look at tetralogy of Fallot, that's over a quarter. That looks like a third of those patients at least, if not more, they're not really candidates. They're ineligible for it. TGA, about a quarter of those patients. Fontane's, smaller percentage, but still, it's something, when we sort of think, oh, the bailout is easy, just put in a sub-Q, not so easy, right? What about cardiac resynchronization therapy? There are issues to consider. Which ventricle is failing? Is it the right ventricle? Is it the left ventricle? Does it matter? What do you do differently? And what's their coronary vein anatomy? I've done a bunch of CRT devices in these patients, and they're wonky. I mean, the coronary vein anatomy is never what you think. This is an acute study looking at resynchronization of the RV, where it seems to help a little bit in certain populations. A lot of these patients have right bundles. Maybe we need to think about pacing them a little differently, hard to say. And this is a large study. I was actually one of the authors in this, where we took 100 patients with congenital heart disease and upgraded them to BiV. And some of these were single ventricle, some of these were epicardial, some of these are mixed. But the ones we did endocardially were all difficult. I cannot tell you that any of these were easy. And some of these were like congenitally corrected. You'd think it'd be easy, but it's not. But on average, the ejection fraction seemed to improve in these patients. It does appear that BiV systems are reasonable in these types of patients. So let's go to a case. This is the final case. See if you've been paying attention. So this is a 28-year-old patient of mine. She had a TGA with a Senning. And then it turns out that she had pulmonary artery stenosis. So the nice thing about pulmonary artery stenosis in her was that because she had pulmonary artery stenosis, the non-systemic ventricle, which is the anatomic left ventricle, had to push a little harder so it didn't become floppy and weak. Okay? So then there was a clever surgeon who decided, well, this is great. I'm going to now go in and band the PA, so they made it even more stenotic to make that ventricle exercise and be ready. And then about a year later, did an arterial switch. And so when he did that, she has now normal anatomy. So she shows up with this EKG. Any takers? It's a little tachycardic, right? And it's hard to sort of tell because the QRS is a little bit wide. But what do these patients often get? They get flutter, right? They often get flutter. Remember that. Remember I said all the patients have mustard and Senning, they'll get flutters, right? They always do. You know, not always, but you know, right? So she gets flutter. She ends up getting cardioverted, gets given a heart monitor and put on Coumadin and Lasix and that kind of thing. And this is what our monitor starts to show. So now what do? So she had some pauses here and then one long pause that was asymptomatic. But here are the other pauses. Do you pace her or not pace her? She's 26. What's the right answer? So the natural history of her disease ends up that a lot of them end up need pacing. And even though technically she is now completely normal, she did spend 25 years as a Senning, right? And those patients in general have this fibrosis and end up needing pacing. And so in this case, we opted to put in a pacemaker. And so she got an AAI pacemaker only because she was fairly young and we were able to pace the right atrium and conduct easily and to sort of prevent her from having, you know, multiple leads. And interestingly, after she gets the pacemaker, she says, boy, I can run on the beach. I couldn't do it before. I was a little bit worried because she had pauses and I was like, are you sure you were symptomatic? You're symptomatic? It turns out that she actually was probably somewhat symptomatic. So a couple of generalized management principles of this. Probably the most important one I would say is define the anatomy and physiology of these patients. And I'll tell you, early on when I started, I told you my origin story. When I started doing this, I would call the whoever the doc was and say, okay, what exactly is this anatomy? Draw me a picture, explain this to me slowly, because I'm just a, you know, adult EP, I don't know. So that's what I did for a long time. And I still do that, right? So if I get a mustard or a Senning or a Glen, I know what that is. But sometimes you get this weird stuff. And what you really, really want is somebody to sit down with you and draw you a picture so you understand what the anatomy is. You also want to anticipate that they're going to have atrial arrhythmias, ventricular arrhythmias. You want to anticipate they're going to have issues with sudden death, issues with leads, and you want to know how to deal with those types of issues. You want to anticipate that they may have vascular issues, all of those things. The ones you will see tetralogy. There's no way you're not going to end up seeing tetralogy. It's out there, right? And so in those patients, you need to understand the risk of sudden death, and I talked to you about the predictors of that, and you need to understand that these are young people who will have device issues, right? You may see single ventricle Fontan patients, and you may need to deal with some of those issues as well. You will see some of the Epsteins as well, and you need to understand what to do with those. But I think if you take anything away from this, you need to know what to deal with tetralogies, okay? Great, any questions at all? Yeah.
How aggressive are you with your VSTEP? And then do you find a monomorphic VT, do you do an ablation between the patch and the outflow tract or between the ventricular?
Yeah, that's a really good question. That is exactly what we do. So if those patients, prior to having any surgical procedure, we actually do an EP study on all of those patients prior to surgical procedure. And oftentimes after surgical procedure, we do a repeat EP study. So we'll often do it on both ends of that. If they do have monomorphic VT, we do tend to ablate them, yes. And it a little depends. I mean, we'll do an anatomical map and see, limited induction. And generally speaking, they're not too bad to ablate. But that does not, even if you're a successful ablation, you still need a defibrillator in those patients, in my opinion. So what we end up doing, the harder question is, you have somebody who's inducible for VF, for example, and they have bad pulmonic regurg or something like that, and they need surgery, because you did it pre-op, right? So what do you do after that? And so that's the reason why we went to doing pre and post EP studies for these patients, to try to sort out that question. Yeah, I don't know. I mean, we've waited a few months, 1 or 2 months, generally bring them back and do an EP study. I had one patient that was positive before, had surgery, and then we brought him back for an EP study. And this is an interesting guy because he was a bus driver, and told him he was likely to need a defibrillator. And he ended up getting a defibrillator. He ended up being very, very mad at me. And he would show up in clinic and kind of glare at everybody. And I actually thought he was going to come in with, and kill me or something. It was very, very scary. But ultimately, he became happy and he was fine. He bought a Harley. So once he bought the Harley, he was good. So, other questions at all? I don't. I only because I generally go with whatever the surgeon's most comfortable with, for one. And then two, a little depends on what else they're doing at the time. So, because sometimes they need to do something else, and then they're putting on the leads, and usually they try to find a way to keep busy and do other things at the same time. So, but if they can get it done with a more minimal procedure and they're comfortable with that and they have good success, I'm fine with that. Yeah, I don't have a good answer for that one, honestly. I'm not sure what to do with that situation. We do tend to see these patients fairly routinely and do put them through, treadmill workups and echoes and frequent kind of testing and look for stuff like that. But it's not, I don't think we have all the answers with that, unfortunately.
In my adult population, I don't often use this approach, but taking care of some of the congenital, we have a little bit more retro-pec access.
Yeah.
Any advice as far as approaches there, use of that, pros, cons?
Yeah, so sub-pec, I think, cosmetically, it tends to be a nice thing. My concern with sub-pec, generally speaking, is I think a little bit of a higher risk of lead problems with sub-pec, depending upon how you do it. There are different ways of doing sub-pec. You can go here, make an incision here, or you can just go in through the same incision here. Both have issues, and both have concerns. Generally speaking, if I can avoid going sub-pec, I will, primarily because of lead-related problems. But what you bring up is a very important point. For example, let's say you have a patient who's has an abdominal can, and you're the EP, and they say, hey, do a gen change. And so you say, oh, great, I'll do a gen change, piece of cake. Well, one of the things you really need to know is where is that abdominal can. Sometimes that's subrectus. And first time I had to dissect the rectus, I was like, oh, this is not what I trained for. So one of the tricks there is to paralyze the patient, because what happens is as you start messing with this, it really tightens up and it becomes harder and harder to pull the thing out. And then two, that may be a situation where you may want to call a friend, right? Because and try to figure out whether that's subrectus or not. Similarly here, finding out whether it's subpec is very useful for your approach. Subrectus, all of these issues, where they put these things matters a lot. A lot of surgeons will put them subrectus, and it becomes a real challenge taking them out. And again, I'm not sure that's something had I known it in advance, I'd be like, oh, let me just jump into this. But once you do it, you get an idea that there is some risk to that. It's not, you could end up going through the abdominal wall. There's problems that you could end up with. So.
What were your concerns, like from a subpec lead standpoint? Is it just the way it works?
Yeah, I think the course of the lead generally, it's a little of one of these things where, the problem with subpec is that they do have a higher risk of lead fracture. Is that because subpec patients are often smaller? Is it because they're younger and they're more active? Or is it because of the course of the lead? So in general, in my mind, I think subpec, higher issue with leads. So I try to avoid it in general. Okay, great. Good job, everybody. Great.
All right.
You're not, yeah, there are too many EP fellows.
Great. All right.
Oh, man, he's a graduate.
Do you want them to grab their sandwich, or do you want them just to get it on the way out?
Oh, I think they can get it now, their food.
They can
Or
get it
just
now?
let them
Okay. Anybody that wants to grab a bag box lunch can do it and bring it back, or you can take it with you. It's your choice. But we'll give you a moment to do that.
I think all the cardiology fellows aren't back, so we don't see them here.
Aren't
There's some in
back.
the blue room.
Yeah. Okay. Why don't we grab them? That's right. Yeah, probably me, and then whoever. Tough one. They're very. All right. Like over here, so everybody could see it.
Over that way?
Yeah, everybody has to be able to see it. Yeah. Let's see. It can't block that.
Let's Okay. People to take some food. I know. Yeah. Yeah, I will. You just rip that thing off. Yeah, you can. Might as well since I'm alive. Oh, wow. Oh, maybe we should. Okay. Oh, that works. Yeah, that works. Oh, that's sticky. You know what? This is on backwards. That's what's oh, yeah. So that's supposed to be on the back. Yeah. This one should be on the back though, right? This front is, yes.
Oh, it just turned around.
So that brown part is sticky. Yeah.
Got it.
There we go. Okay. Awesome sauce. Now it looks so much prettier.
We have how many? One? How many tables? 6, I think. Do we have 6 tables? Okay.
Yes. We'll put them in points. All right, small.
Yeah, we're hard fellows.
Well, there's supposed to be fellows here. I'm not that smart. I'm just somehow bad. I need one adult fellow with beef puffs and beef sticks. We should be a beef TV fellow over here.
We can join teams. We can join teams.
This is a cardiologist committee.
All right, so we have to double check. Everybody has one card.
Well, no, this is the only cardiologist table, but that's all. Now, what if we shift this table when? It's all cardiologists. Well, yes.
We have to separate them.
So maybe if one of you can go to all the other tables, you don't need this table, if you don't mind.
There, that's a good idea.
Yeah. How many? Don't we have 5 tables? Is
5.
that right?
Then we have 5 people on each table.
I think this is, there we go. That's here's a microphone. You can,
Yeah.
Perfect.
All right.
You got one?
Yeah.
One?
So just join.
Okay. Oh, I see. That's how we ended up. Okay. It is what it is. Okay, great. All right.
Get a microphone.
And so,
Microphone. So one person's the phone. You can scan.
5, right?
Hey, join us. Somebody's
So join a table.
5. Yeah, 5 is right. 5 is the right.
over. We got
How many do we have?
I'm sorry.
Oh, you have 6. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. Oh, okay. You're right. You're right. We have to pull off a couple people.
Honestly,
So let's make 4. Some groups have 4. So let's pull out a couple from 4.
only one of us makes a name, or how does that work?
One volunteer to move. Yeah. One EP fellow to move to that group. Or which table?
Wow.
These are kind of spicy a little bit.
Are they?
Good.
No.
Interesting.
That's the hard string.
Can you come to that table?
Over here.
All right.
5. 5.
So this is 5. 1, 2, 3.
The last grab a chair. Just grab a chair.
Yes.
But this has 6. So we got to pull one of these from here.
Come here.
Just for fun.
Yeah, one person from here.
But Ben, you said 5.
And I need to get
Five. Has to be 5. No,
my flight.
no more than 5. It could be 4. 4 is okay. Oh, here we go. Yay. Are you going to move?
Let me.
Yes, Lucas, you're going to help us out? Okay. Yeah, okay. So they'll have 3, and we should pull one more person to get a minimum of 4. So any place.
Here's the microphone.
Yeah, so let's find if there are any missing people and then make sure that they're okay. So how many EPs in this table? 3? PTP 3? General, so 2 and 2. Okay, cool. Okay. How many EPs on this table? 1. 2 EPs? Yeah, okay. So you have 2. And you're general? Okay, perfect. Great. And how many EPs in this table? 2 people. Okay, great. How many EPs in this table? Oh, so you got 3. Okay, they're the opposite. How many EPs in this table?
We have too many.
How many do you have? 5 EPs? Oh, okay. So they have 3. Okay. How many EPs on this table? 2 PVP and you're general? Oh. Okay. And how many EPs on this table again? 3. Okay. How many EPs on this table? 3. Okay. How many EPs on this table? 2. Okay. We need one of you, whoever wants to move. Could you move to that table over there? That'll make it more even. Okay. Eeny, meeny, miny, mo. Who wants to move? You're going to move? Okay, thank you very much. So go to that team. So we're pretty even. We're the closest. They have 4 EPs. Everybody else has 3 EPs. So I think we're good. All right. So we're good. So everybody has a number, right? Everybody has a number. And we have to designate one person to vote.
Yes, one person.
Okay, so you're going to be the voter. Who's going to be the voter here?
I don't know.
Designate one person to do the voting. Yeah, one person votes. So designate one person to do that.
So does everybody
Who's going to be the
have a
voter
table
here?
name?
I'll do it.
You're okay, good. And
Number.
who's going to do the voting here? One person. I can do it. You can do it? Okay, great.
All right, you're whatever you want to be.
Who's going to do the voting here? One of you should do it. Okay.
So name your
Great.
table.
With your number.
The number. The number
your
is good
number.
enough. Yeah, they don't.
So they can't
they
have a
don't-
fancy number. They can
Yeah.
have to put the number too.
Okay.
All right, so let's make sure. So
2 and their name.
2,
4 QDs.
3,
There's going to be like a poll about it.
5, 4,
I'll put 4.
and 6. Right? So all we're missing is 1. So that's good. Okay, great.
We're down.
All right. Let's see.
Something's wrong. We're good.
He's going to activate the poll.
Oh, but you have 4
How are we going to control this?
So,
Because I was thinking I was going to, because it's kind of hard to talk you through.
Yeah, I was going to say. Maybe
I think I am. I'm 4, so
Yeah, that's smart.
yeah. So we're all.
It's like where we all go to see how everybody.
Which one? Illinois. You're Illinois.
It's like hiding.
You like it?
That's right. Yeah, Rich is at it.
Wait,
We're for it.
So just to confirm, everybody has their table number and a table name. Picked.
Oh, shoot. I kind of just put us as 4, but.
Sweet. Smart move, man. I like the way you think. It's awesome. No confusion. Yeah, no confusion.
All right, we good? Are we doing a...
Right number.
You guys want to win?
Oh, yeah.
Are you winning?
Yeah, okay.
I don't know if I can. Let me. No way to do that.
All righty, we're going to have fun here. I don't know. Boy, this is great. Okay, so we're going to start, right? Everybody okay to start? Yes? 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 Yeah, we don't have a table 1. So we got 2, 3, 4, 5, 6, right? Right? All right. Cool. All right. We're going to do a table call out. Table 2. Yay. Okay. Table 3. Yay. Table 4. Yay. Table 5. Yay. Table 6. Yay. All right. They're very quiet back there. Okay. All right. All right. So, okay, we're good. So let's, so this is Jeopardy, but you have to put the answer in, and we're going to see who the fastest person is. So it's not only correctness, it's speed.
So
you're going to have to communicate quietly so you don't give your other neighbors the answer, but you got to figure out how to get the right answer quickly. So this is the challenge. So needless to say, we're learning on the fly, so be very patient with us, please. And we'll have to see. Oh yeah, no, these guys are like 2 seconds. What do you mean? They're very super fast reflexes. So we expect them to come in about 2 seconds. All right, and so the idea is that for correct answers, like Jeopardy, you'll get the value, the dollar value, the $100 there. And otherwise, if you lose, you'll be negative. So we have a very mathematically talented person here who's going to figure all this out. So bear with us. All right, so you can see the categories, and I'll take anybody from any table, but I'll turn to you guys. Where do you want to start first? You guys. Table, what are you, table?
4.
4, okay, table 4. Go ahead, pick a category and a value. Yes, oh, sorry.
These are in order that they were in the slide presentation, so I don't know if we can randomly.
Oh, you can't?
Well, because they're in order, we can't pick one question at a time.
Oh, I can.
You can?
Yeah, I'm pretty sure, right? That's the way I set it up. So literally you go like, click, it opens up. It actually magically works. On my computer it does.
Just because it's a quiz instead of a...
Oh, it's a quiz.
Here.
Oh.
Not really, but...
Oh, sorry.
Can we just go in order?
You can go in order. Oh, boring. Okay, that's all right. Yeah, well, we'll go in order. Oh, that's too bad. Okay, I thought we were going to have some real excitement. Yeah, so some of them are really easy. Some are, okay, sorry for that. Okay, misunderstood. Okay, so we'll go, I guess, left to right. I suppose we might as well. All right, and if we have time, there'll be Final Jeopardy. So we'll watch the clock. So when are we supposed to finish? Ooh, noon? Oops. Okay, we won't finish then. All right. Okay, so let's get started. ICDs for 100, and so again, speed is important. The year the ICD was FDA approved: A, 1980, 1985, 1990, 1992, and 1994. Please vote quickly. All right, so hopefully everybody's voted, and we can put up the scores quickly. So this is not helpful. So what we need to do is a system that will tell us who selected it first, and then we got to figure out who was right. Do you have a way to do that? Otherwise, we're going to have to adapt it on the fly. Does anybody know how to do that? Can you put up who came first, like who voted first? Is that knowable?
Oh, that's correct. 1985.
Can you do that?
Yeah.
Oh, you are good. You are good.
Nice.
But so we don't know what these mean though. I don't know what is that table 5, but what's table 2? You see what I'm saying? How do we figure that out? Huh? They won. They're the earliest. But what was your answer? 1985. Okay, so they get 100 points. Table. What are you in? Table 5. Is that right? All right. You get 100 points. Okay, let's keep going. All right. All right. You guys can figure it out. I'll just go on. Oh, I thought we just do one person. Yeah. Okay. Yeah, I think so. Okay. So for 200. Go ahead. ICD for 200. Study showing improved survival in EF 35%, class 2-3 heart failure, immediate ones, gut heft, MEOD, AVID, or must. Please vote quickly. Should be really fast. Right? Okay. All right, let's see. So again, same thing. That little table, I think, is the thing, but you're going to have to help me figure out who answered first. All right, let's go ahead. I think that's plenty of time. Go ahead. Otherwise, we're never going to make it. So, what do you mean, table 5? 14 seconds was 4, right? Wasn't that right?
10 seconds.
No, why? But, 10 seconds. Oh, yeah, you're right. Table 5 again, and the answer is Scud heft. Okay, 200. So, okay, very good. Let's go back to the board, and ICDs for 300. What is this? Capacitor, step-up transformer, diode, dead man switch, resistor. Please vote quickly. Seems like it's working well. Yeah, it's working well. I'm very impressed. That works really well. Luckily, I know the answer on most of these, so that should be okay. All right, so, okay, let's see how it goes. This is a first try for us, so we'll see if this works out. All right, so who hit the button first? Okay. We're not going to tell you the answer. I'm going to see who get it first because we're going to ask them. Okay, so so put us a little table again. The who's first? Who's first? Back to that little table, the timer table. Oh, okay, good. So it's 5 again. Oh, oh no. There's They're tied. They're tied. Okay. Oh, I don't know how to deal with that. 20 and 20. I have no idea what you're supposed to do if there's a tie.
I think they're adding. It's adding because it was like 5 seconds, 10 seconds, 20 seconds. It's adding the time. That's your total time.
Oh. Can you reset the timer? Every time, like instead of adding, you guys are smart. Instead of adding, can you just go to 0 every time?
Definitely an additive process here. Now it's at 30 seconds.
So who did win then? So maybe number 4 won because they had a higher before?
We're not showing up.
You guys aren't even showing up. You're not even
Should
showing
we
up?
move to manual? Like just raise hands? Should we
Oh,
just
they're
go
not
there?
even showing up?
We're not even on there either.
They're not even on there either? Oh, okay, so what should we do? Sheeta, what do you want to do? Hand raise? Okay, hand raise. So someone has to watch for the hand raise. I'm not going to be the one.
Rich is the watcher.
So someone has to figure out who the hand raise is. All right.
What table?
Let's go back to, all right, so let's do that again. Okay, so show us 300 again.
Just watch.
All right, so we're gonna do this again. So this is ICD for 300. Raise your hand.
Right there.
Okay, right.
He's first.
So what's the answer?
Capacitor.
Capacitor is wrong. Oh, sorry. Okay, who's next? Resistor. Wrong. Okay, who's next?
Corner.
Step-up transformer, yes. Okay, that's for 300. That is team 6, right? Are you guys 6? 6, okay, 6, 300.
What happened there? Wait.
Oh, each one of them lost. They all lost. You have to do minus. You have to do minus for the other 2 tables that answered. See what I'm saying? Yeah, you got to. Yeah, sorry. Sorry about that.
Table 2.
Table 2, minus 300. And who was the other one? You guys? Who is this? 3, minus 300? Yeah, sorry. All right. Okay, everybody, ready? So we're going to do...
I think the 200 was incorrect, though. Yeah.
What table? 3, 5.
All right. Well, whatever. Okay, we'll keep going. No, they're just complaining about the previous answer, but that's fine. So we're gonna go on. So ICDs for 400. Okay. So again, the first hand that goes up, who's gonna rip?
We're
You guys?
watching it. We're watching
Okay, great. The patient has sustained monitor VT that's minimally symptomatic during this tachycardia. The patient received 1 shock for each of the several episodes. Which is the best strategy?
Corner table.
A, program on, anti-tachycardia pacing. B,
And then number 2.
yeah.
You got it? First, left hand.
Oh, who's first? Who's first? 6 is first?
Yep.
Okay.
Program on option A.
Anti-tachycardia. That is correct. Okay, so for 400. Table 6. Okay, they're up to... Okay, yep, great. All right, so next, ICDs for 500. Indications for ICE, all except coronary disease, EF less than 30%.
Corner, right here. Team 2.
We're going to say C.
Who did?
Right here. 2.
Oh, 2.
2,
yes,
this one.
that's correct. Less than 40%. Okay, excellent. Good job.
EF less than 40%.
2 is 500 points. Yeah.
All right.
So you're going to add these or not?
I just have to see it.
They had 300.
Yeah,
minus
but see
300.
here, didn't
And
they?
okay, so they got 500.
Yeah,
Now they have 200.
yeah, but here, aren't they up to 700?
He is very good with math.
Yeah, okay, very good.
Team 2.
Is it? Yeah, I think you have to be consistent as to what it is. Yeah, that's good. All right, so we're going to do it in order. Pacing for 100. Okay, let's go pacing. DDDR 60 to 100, AV late 220. When QRS activity is present, the QRS occurs in
Right here,
one
right here.
blanking period.
What number is this? Right here is the first.
4. The answer is 2. Crosstalk safety pacing window. Is that what your answer is? No, incorrect. Minus 100.
Right here, this guy's
table 4, right?
6.
Table 4 is minus
4 is
100.
negative.
Thank you.
Who's next, Rich? Who's next?
They were next, and then you're after.
Okay, 6. Okay.
100.
6 is answer 1. Ventricular blanket period is correct. So plus 100 for 6. All right, let's go back. Let's go to pacing for 200. The mode shown here: VVI, VDD, DDD,
Table 3.
DDI.
BDD.
This one? So this is table what? What is
Table
this
3 got it wrong.
3 minus 200 for table 3. Who's the next one?
Right there.
Number 6? DDI, yes. So they get plus 200 plus is 6, table 6.
Thank you.
All right, pacing for 300.
Keep your hand up the whole time.
The cross-chamber blanking period indicated by the arrow is called PVAB, PVARP, ventricular
Number
blanking
3.
safety.
No, they had it up. He actually premature hand up.
Oh, that's okay. I don't care. They can answer it. So who is it? Who is it?
All right, they wanted to give it to the
who is
gals.
it? Which one?
This one. 2.
We're saying
Oh, the one in the back.
Wait.
Back there?
PVAB. Answer A.
Yes, PVAB. Yes, exactly. Post-ventricular atrial blanking period for purposes of timing and et cetera, far field sensing. So that is 300 plus 300 for that table there. Okay, pacing for 400. Patient complains of red eye,
Corner
headache.
table
What's
again.
the
Number,
cause?
what is that? 3? 2. Right there in the corner. Or this way. Look here.
Which
They
one?
were up.
Which one?
Left. Go ahead. Answer.
You guys? Is it table 6? Okay, table 6. What the answer is?
SVC stenosis.
SVC stenosis. Yes, correct. You saw a case like this. All right, that is 400 for table 6. Okay, great. Okay, pacing for 500. Okay, let's see what it is. What is the likely abnormality? Well, it says, what is the likely cause of tracking of the P wave? A, ventricular oversensing, B, atrial lead dislodgement, C, atrial lead perforation, and D, MVP.
All right, Kay. She's been thinking about it.
I think it's MVP. Answer D.
That is table, what is it?
2.
No, that's incorrect. Minus 500 for table 2.
Who's next? Quick, pick your hand up.
Okay, next.
All right, table 5.
Atrial lead dislodgement.
So that's incorrect. That's table,
All right,
is that
number
what
4.
table is
Table
that?
4. Yep.
That was table.
That was 5.
5 minus 500 for table 5.
Wait.
So
4.
this table's next.
4 next.
Table 4 is C, atrial lead perforation. No, minus 500.
Number 3.
for
Table
that.
3. What's left? Ventricular oversensing.
Hey, ventricular oversensing, yay! Because the atrial sensitivity is, the P wave is fine, and so it's not undersensing, so it has to be oversensing. Yes. So 3 got that.
3, Bebe.
Plus 500. 0, yay. Okay, let's go back to the board. So we'll go to the next category. So go back to the board. EGMs for 100. The most likely rhythm, so sinus tachycardia, atrial flutter, atrial tachycardia, ventricular tachycardia, double tachycardia, none of the above for 100. So atrial.
3.
None of the above.
None of the above is incorrect. That is
who's next?
minus 100.
Corner
for
number
3.
6. Is that 6?
Who's next?
Wait, 6.
6 is next. Minus 100. Yeah. 6. Your answer is? What is it?
Option B, A tag, A flutter.
That's incorrect. So minus 6. Table 6 is minus 100. 2. Your answer in table 2 is?
Ventricular tachycardia.
Ventricular tachycardia, yeah. So there's far field sensing actually. So those the few things that you see are actually atrial. So it's a V greater than A. It's C, atrial ventricular tachycardia. And that's table 2. They get to 100 points. Yeah, good. All right, back to the board. Egrams for 200. The most likely rhythm.
All right, number 6 again. 6 was first.
You don't even know the question.
No, you got to answer, please.
No, they don't even know the question.
Well, that's okay.
We got to give them the question. So that's next. But they're the ones that are going to answer it. So
All
go.
right.
I think go to the next.
You gotta answer before the question.
Oh, okay.
That's true. Let's do that.
That's
I like
fair.
that.
I like that.
What's the answer?
Go ahead. Sorry, what is it?
It's stream track.
What is it again?
T-wave.
T-over is correct. Yes, it is.
Oh,
Yes.
man.
So that's
Nice
number
try, Ian.
6, table 6. Okay, good work. Yes, it is indeed. So yeah, good work. Very gutsy. Yeah, but okay. All right, egrams. I like that. I'm with you. Okay, egrams for 300. All right, so this is the tracing, and we'll give you the question coming up, I think, on the next slide. Next. I hope the question is on the next slide. Yes. Why does atrial undersensing occur? A, small P waves. B, autogain. C, P and PVAB.
Table 5. Table 5.
P and PVAR.
5.
Table 5. And C is correct. The P wave is occurring in PVAB, and then what happens, the ATP changes the relationship slightly between the atrial and the ventricular, so it's no longer in PVAB. So that's correct. So that was 3 plus 300 for, yeah, okay, great. Egrams for 400. Okay. So you see this little impedance graph, you see thresholds, etc. And the question, I hope, isn't coming up on the next one. Which is true? Is this A, header connector tissue fracture?
6. Table 6.
Can we show?
Table 6.
Yeah.
Table 6. What's your answer?
We have an answer.
They're the first choice?
They are the first.
Okay, so you got to answer. Go ahead, what is it?
Calcification, option D.
It is
D.
correct. Calcification of the ring electrode. This is from Dr.
All right.
Swerdlow, courtesy of him. Thank you, Dr. Swerdlow. Okay, great. So you got that? Okay, great. So egrams for 500. Oh boy, this is really ridiculous. Okay. Ooh, I don't know that this is, okay, well, let's see. Okay, so yeah, look at this one and pay attention to what happens, and we'll show you back the tracing. What happens that leads to ATP? The VT counter reaches 8. The VT counter is
2.
reset.
Table 2.
Combined counters are 28. And sensory resets. Yeah, okay, table 2.
D, undersensing resets the VF counter.
D, undersensing resets the VF counter. That's not what causes the ATP
Next
to occur.
hand.
So minus 500 for 2.
Who wants to go? Well,
Okay.
that was an
And
incomplete.
so who's
number
the
3.
next
Number
one?
3 is next.
Number 3 is next. So go to the questions again. So what's your choice? Go to the question second. There. And what's your answer? The C is correct. The combined counters each 28. It's a combined counter VTVF. You have to accumulate them to what's required, and that's what causes therapy to deliver. So that's, you got the plus 500? Okay, good.
Get to the wrong team.
There are 3. There are 3. Yeah, there you go. All right. So,
Ashita, get up here. Help her out.
Okay. So more egrams. These are pretty easy. So speed is critical.
Yes.
Which of these is seen? A electrogram and V electrogram.
3 or 2. Sorry, 2.
D, VT.
VT, yeah. So these are pretty easy. You're going to just have to be fast. Table 2 plus 100. Yeah. So these are really
Make sure she
easy.
gets in the
You just
right
got to be
column.
really fast.
All right.
So ready to go. Okay, your hands up. Okay, egrams for 200. What's the
2
problem?
again.
Lead fracture, EMI, loose sex screw.
Table 2.
Table 2. What the answer is?
It looks like EMI.
It is answers EMI. That's correct. Plus for table 2 plus 200. So again, these are really easy. You just got to be super fast. You can all get these. All right. More egrams for 300. Is this
two again.
ET, lead fracture,
Then
or
three,
EMI, or none of the above? Which
2 again.
Table 2 again.
B, lead fracture.
B, lead fracture. Yeah, these are easy, right? I mean, you've got to be plus 300 for table 2, yes. These are very easy, right? But you got to be super fast. Okay, so E-grams for 400.
She's already got her hand up. 2.
Well, that's the point. And if you have confidence, that's what you should do. Okay, go ahead.
2.
Go ahead.
It looks like AT. We're going to say AT.
AT is correct. It's atrial tachycardia. It's 2 to 1. Yeah. 400 for table 2.
I think someone's got to put taper on her arm.
All right, so E-grams for 500. Okay, again, this is speed. What's the rhythm?
That's a half of a hand. Okay, you go. Number 2.
Number 2. Go ahead. Yeah, what number 2, what is it? You gotta go. You
Want to get her buzz?
5 seconds.
3.
AF and VT.
AF and VT is correct. Plus 500. Yeah, we're gonna give it to him. Table 2. All right. So the final category in Jeopardy is CRT for 100. Among the following, which is the most useful in assessing
5
response?
6. That's 6. 6.
That's incorrect. Minus 100 for table 6. So who's next?
Give it to 3.
You have to wait for, so which table, Rich? You're calling like table 3.
2.
Oh, you're saying table 2? All right, so what's the answer to table 2?
You were
A, LV, ESV, plus 100, table 2. All right. Okay, yeah, I know. CRT for 200. Okay, here we are. Which pacing pair is most likely to result in this phenomenon? LV tip to RV ring, LV tip to RV coil, LV tip to RV ring.
2.
LV tip to RV ring.
That's correct. Anodal stimulation, small surface area, current density is high. It's A. So plus 200 for that category. Okay, great. CRT for 300. Optimal method to obtain.
Corner. What do you got?
Table 6, is that right?
Yeah,
we're asking.
Yep.
Table 6, what do you got?
Option B.
B, aortic velocity time interval. That is correct. So plus 300 for table 6. All right, so we're getting to the end. CRT for 400. Resynchronization allowing intrinsic is as follows. A, LV trigger response.
3.
LV
Table
base
3.
before RV sense. Biventricular pacing. Yes. Table 3.
4.
Quickly. What is it, B?
B.
LV pace before RV sense. That's correct. Adaptive response. Yes, okay. Or adaptive CRT. All right, so plus 400 for table 3. The final for Jeopardy is the condition that must be met
Table 3.
For BIV pacing to resume is.
Table 3 got it.
Yes.
Yeah, BBC.
That's correct. PEP is greater than PR plus PVAR. That is correct for 500. So, okay, great. So what are we left at? So entering final Jeopardy, which will be next, is 1,600 for group 2. 1,300 for group 3. Sorry, table 5. Minus 100. And 2,100 for group 6. All right, very good. So we're going to go into Final Jeopardy. So I think everybody, unfortunately, other than Group 5, can play in Final Jeopardy. And you're allowed to wager any fraction of your amount, the total amount or 0. So on one piece of paper, I want you to write down what the number is. So decide what it is. The Final Jeopardy is going to be a combination of ICD and pacing. And so
Flip it upside down.
No, put your number on it.
So why don't you?
Team, what team? I'm not going
put
to
the summaries down each one. Yeah, thanks. All right, so everybody got that right? So you're going to, as a group, unfortunately, except for table 5, put down how much you're going to wager of your total amount. Everybody know what your total amount is? Yes? Yes, everybody know? Yes? Okay. So tell me when everybody, raise your hand if you've done that.
We'll just put it here. I'll leave you.
Oh, you'll leave it there. Okay.
Yeah.
Everybody have it?
Yeah, we're done.
You have it? You have it? You have it? Or, okay, you have it? Yes, you have it. Right? Okay. Yes, yes, okay. So you will not yell the answer out. You will write down the answer on a piece of paper. Okay?
You can use the same paper.
I'm going to repeat that. You are not to yell out the answer. You're going to write down the answers on a piece of paper. Okay? You got that? Do not yell out the other answer, okay? All right, so do you know where to go? Do they know where to go on the Final Jeopardy? You guys know where it is? Okay, you do. Okay, so we will give you a time, right? So we will give you, what is it? We'll be generous. We'll say like, what do you think? How long should we give them? Maybe.
Can you do the Jeopardy music for this one?
How long? We'll give you.
Or I can do it on YouTube.
2 minutes? How about 2 minutes to answer this? Okay. All right. Okay. So let's go to the next slide. I hope this works. Next slide. Okay. So this is what it is, and go on and answer. There are 3 questions. Okay. So question 1 is. So go to the next slide. Sorry. So don't yell these out. So the condition that must be met for biventricular pacing to resume. We're going to show you these over again, so don't worry, okay? We're going to show you question 2 now. This is the following ICD question. You're going to answer yes or no, so you have to be correct.
Eyes are going like.
Does the ICD confirm the shock? And we're going to show this to you again. And so the timer hasn't started yet. And then question 3 is, what are the names of point A and B? Oh, sorry, I didn't label it. A is the one on the left and B is the one on the bottom. Okay, so now we're going to go back and show them to you again, and then we're still not going to start the timer until we go through all 3. So go to the first one again. Back, definitely don't go forward. Go back, thank you.
Definitely go.
All right, so the condition that must be met for biventricular pacing to resume. So I'll give you a moment to write something down if you would like.
I think so.
Okay, everybody write something down? Yes? Everybody got something down? Okay, we're going to go to the second question and go to the next slide. Does the ICD confirm the shock? So I want you to write down yes or no. Does it confirm before the shock? Okay, everybody have an answer? I'll give you another few seconds to do that. Does the ICD confirm the shock? Okay. Everybody okay with that, more or less?
He means is it something?
Another few seconds. Oh, they want to look closer? Good idea. That's fine. We'll give you a few more seconds to look at this.
Confirm before the shock? Confirm before the shock?
Does the ICD confirm at the time of the shock, right before the shock? Yes, that's correct. That's the question. Yes or no? Okay, so let's go to the final one. Okay, and so A is the one on the left and B is the one. I'll take it in that order. What are those 2 terms? Again, don't yell them out, but just write them down. What is A and what is B? What's the one on the left and what's one on the bottom? What are those called? We didn't talk about it, but don't yell them out because people are going to hear it. So go ahead and take a moment, try to figure that out, and then we'll come around and I'll give you another, minute to kind of review this. So I'm going to start a minute, and after a minute, we'll ask you to finalize your answers. All right. Okay, so everybody is done, correct?
Yes.
You are done. All right. So if you are done, I'm going to ask table 3, how much did you, where's table 3? Right here, right? You're the lowest, right? Is that my correct? You were 1,300, is that right?
The lowest of the remaining people.
The lowest of the remaining people. Oh, yeah, sorry about that. Okay, yes, that's right. How much did you wager?
All of it, Alex.
All of it, Alex. Okay, all right, good thing. So 1,300. And so what are your answers?
For A, we said that was
So go back to the question 1,
sorry.
if you could, on the slides for us. So what is your answer?
PP needs to be greater than PV or ultimately PR plus PVARP.
PP is greater than what?
PV plus PVARP or ultimately it could be PR plus PVARP. But PV plus.
You have to have checked it one or the other, because it's resumed. So
it's resumed, so PV, sorry.
You said PV, okay. So what's your answer to your second question, second part?
Oh, yes.
That's question 2. What did you answer? Yes or no?
I can't see it, but yes, yeah.
You said yes? Okay. And what is the answer to your third part?
And the top one we said A, sense, and the B is pulse width.
Okay, all right. So I'm going to give you the correct answers. So for number, because everybody's written it down, right? You've all written it down. Is that correct? You wrote down your answers, right? You can't change your written answers.
Yes.
You can't change your written answers. All right, so let's go back and talk about what it is, and we'll go to the next one. Oh, you want me to hand them in, he says. Okay, hand them in. Okay, all right, fine. I trust you guys. You're okay.
Oh, he's changing his
All right, so go ahead and hand in.
All right.
So table 2, how much did you wager? Table 2. No, table 2, how much did you wager?
Table 2.
I'm not. Oh, what's that?
That's table 2's answers.
Yeah, no, but yours?
They already submitted.
Yeah. Okay, how much did you wager table 2?
He has
Oh, 1,600. Okay, everything. Okay, good. And your answers are PP is greater than PV plus PVARP. Yes. Cronaxi and Riobase. Okay, so that's your answer. Table 6. What is your? Well, how much did you?
6 is right here.
1101 we waited.
1101. Okay. Oh, wow. Good for you. Okay. Oh, wow. All right. That's pretty smart. So their answer is PP is greater than AV plus PVARP. No, Cronaxi and Riobase. Wow. Okay. This is problematic, actually. But okay. So let's go ahead and show you the answers. So go forward in the slides. So what is the answer to this? Well, it's PP is greater than PR for resumption because you have to take the P to the QRS because it's intrinsic. You're resuming, right? And then you want to go to the next one. So it's PR, unfortunately. So nobody got that, unfortunately. Okay. Go to the next question. So is it appropriate, yes or no? Yes. It did confirm, basically. And so we can go back to this couple slides back and show you that. So go back a couple slides, one more. Yeah, okay. So it actually looks like it isn't appropriate, but it takes the last intervals in terms of whether those are fast. And that's why it said, those are fast, we'll count it. So it shocked the person. So the answer is yes. And then the last one is, so go ahead. Oh, maybe I didn't provide the answer. Riobase and Cronaxi, not Cronaxi and Riobase. So I don't think anybody got any of them right. So as a result, the winner is Team 6. Unfortunately, they're 0. So I guess, what do you want to do for the remaining team? Okay, very good. So table 6 is our winner. Thank you very much. Yay, good job. Yeah. That's up to them. That's up to you all. That's up to them. I don't know how you want it, but I don't know how to pick them. So you have to decide. So very good. Well, thank you. Ashita, did you want to do anything else or?
Final comment.
So, well, we'll need to get a picture with table 6. We have the textbooks for you with faculty, so stay, don't leave. We need to get a picture. So before everyone goes, can we just please thank our faculty, those that are still here. Huge effort. Thank you to all our visitors from Puerto Rico, from Minnesota, our technical field engineers. Thank you. And to our AV team and Marna and Sarah out there for her birthday. Thank you to everybody and to all our virtual attendees. And with that, the course concludes. Safe travels. If you have any flight situations, please talk to Marna and Sarah out there, and thank you again. Cool.
To Medtronic and their team for putting on a spectacular, I mean, they really put their heart and souls into this, as you can tell. Really, our field is very grateful, and everybody here, I hope, is as well. On your way out, say thanks to everybody, and the desk as well. Thanks to the terrific AV. You were flawless. It was spectacular. You were really great, and all the teams, the technical support team, and to the wonderful faculty on behalf of myself and Dr. Russo. They hung in there, as you know, long days, really good. But we hope you'll go back and tell your colleagues this was a great course. Please attend next year. Again, I think the workshops. I hope you really enjoyed them. The faculty obviously labor over those, and hopefully that's something that you found useful. So thanks again for participating. Thanks.
Thank you.
Thanks everybody for coming. Thank you.